to show from the top. You can.
कैमरा इधर से ला लो मोहन.
ऊपर से थोड़ा दिखा. आपके पीछे से अगर आ सकता है.
This is C2 spinous process.
Just hang on. We have a blackout. No picture from your end. It will come.
Now the picture is clear, Lucky.
Now we can't see anything on the screen. I'm waiting.
Just a minute. Just a minute.
So we checked that it was working well. Ajit.
Sir,
नहीं. Should come. वो flickering कर रहा है.
sir, can you see now?
Not yet.
Okay, 1 minute.
Okay.
This is the incision. Sir, so this is the MRI image. You
Yeah.
can see the atlantoaxial dislocation with cord compression here.
So if it is a mobile AAD, why didn't she present earlier? Was there a trauma? So this is what I'm trying to ask you. Or
No,
is
no.
there?
Sir, she didn't have any trauma. Maybe she had a trivial trauma, but no major trauma history.
That's what I'm asking. Okay, please
Yeah.
carry on.
So this is the CT images. So this upper one is the flexion and the lower one is the extension. You can see that in flexion, the atlantodental interval has increased significantly and it is
Yes.
reducing not completely, but nearly completely on extension. You can see the
Yes.
facets. Here, the vertebral artery does not seem to be that high riding. So that is good for us.
Where is the artery?
This is the groove. Here, can you see my
The
finger?
groove, yeah.
Yeah.
Okay.
And here you see the type 1 facetal atlantoaxial instability as classified by sir.
Yes.
So these are the images. This is the 3D recon. Yeah, you can see the images, sir.
Yes.
Yeah, so here you can see the atlantoaxial instability.
Yeah.
Okay, so I think we are ready to start. We are draping now.
Yeah. So the groove angiogram normally, I think. Abida,
Yes, sir.
Dr. Barsal is asking whether you have an angiogram on this patient.
No, we have not done an angiogram. If we are we are suspecting some abnormality or if it is a complex craniovertebral, then we do an angiogram. Routinely
Okay.
for our cases, we don't do for all, but you can do if you want.
Atul got a color microphone?
Yes, he has.
Okay, I can see him. We can see him.
Just a minute, I'll make them on that. One second.
Please.
Mohan?
Lucky, can you hear me?
Yes.
Okay. So whoever has come, I welcome all of you.
Thank you.
And I hope to show you some good cases. After all, these are working on patients, and it is live neurosurgery, so we cannot. This is not a theater or theatrics is not acceptable. This is a after praying to God, after bowing in front of the God, we have to start our cases. You agree, Lucky?
Absolutely, absolutely. That's a very important thing, like you mentioned.
This is not see what I do and see how I can do. This is not like that.
Yeah.
This is working on a real patient. Their families are waiting outside. So now first case, what I'm going to show you is atlantoaxial instability. And
Mhm.
I have one more case, I think, of atlantoaxial instability, which I will show in the subsequent part of the day.
Yeah, Atul,
Yeah.
I was asking Abhida that this is a mobile AAD. So what is the natural history of this? Because he presented at 53.
See, that is another very important question. See, atlantoaxial joint as
थोड़ा वॉल्यूम आपका बढ़ाना पड़ेगा थोड़ा सा.
okay. Okay.
Thank you.
Okay. Atlantoaxial joint is the most mobile joint of the body. Atlantoaxial instability is the most common form of instability. And atlantoaxial instability, the one word which I don't like to use is congenital. Atlantoaxial instability is never congenital. It is always acquired. When is the injury, that we have to find out, whether it is during pregnancy or in the post-fetal state or neonatal state, nobody knows. So this word congenital is not such a great word. So what my concept is, atlantoaxial instability occurs sometimes during the later part of fetal life or in early neonatal phase when the child has not yet started holding head.
Mhm.
During that time, some injury occurs and it may be mild, and such injuries are more common in our country, in India, because of the poor delivery practices, use of forceps to a greater extent, and poor malnutrition. Protein calorie malnutrition is very much in our country. So that is the reason these problems are much more common in India than in anywhere in the world. That is one thing. Second thing is congenital word is not correct. And now you will ask me, in this person who is now 53-year-old, what is the cause?
Mhm.
The cause is, weakness of the muscle, like degeneration. It is a degeneration. Now, you know what? Let me just show you the images.
Yeah.
Okay, let me show you and how I plan my operation. See, when I see the images, where is the coronal image? Either.
3D में है शायद.
See this coronal image, Lucky, are you hearing?
Yes, yes.
Yeah, coronal image is very important and critical. You see here, the vertebral artery groove is quite high
Yes.
on this side.
Correct.
And if this other side is okay. So that is what bothers me. That is what I'm concerned right in the beginning of operation.
So
And
you look at the groove and you don't need an angiogram. Always.
no,
That's
I
what
don't.
You say
Yeah,
with your
that
experience.
that groove is a clear indicator. There is no need for any angiogram in general, but in complex cases, when the bachelor invagination and assimilation of atlas and complex cases, I like to do angiogram, and also sometimes I like to do 3D printing of the area. That is in complex cases. So let me begin.
Yeah.
So I'm just taking the graft first, okay?
Okay.
Good for second night. Now just
So fusion rates have
निकाल निकाल Diesel hammer. So first I am taking the
rest. Atul,
yes,
Suresh is asking, Professor Nair is asking,
yeah.
did you have any trouble with the graft site problems like pain or something else that
Ne-
you?
Never really, never. To answer that
Yeah.
question, I will say never real problems. You know what I do?
Best graft anyway. So he is also saying that you can get substitutes, but probably you like the real ones. So this is our first surgical workshop after the COVID, Atul.
What's that?
This is your first workshop, surgical workshop after the COVID.
Yeah.
I just, and also your change of place of work.
Yeah.
So that there's ample time for you to get adjusted to your speed and quality of work.
Let us see. I'm trying my best, Lucky. I'm
Yeah.
trying my best. Okay, so show the graph to show the graph. So I have taken the graph, Lucky, if you have seen. And now I will move on to the next step of cranial operation.
Sure.
Here is the graph. You see, can you see the graph?
Yes. Nice ones.
Okay. Toothpaste and scissors. Light डाल बराबर को. Light. So I'll take the microscope maybe right from the beginning so that you can see properly.
Yes. Normally you do that, but
Because you know what, with this, you may not be able to see through the microscope.
yeah.
So मेरा वो instruments lab.
You won't be feeling out of place because everybody, all of your staff are there with you.
Yeah, I am completely at home, my dear friend. My friends are in the audience also, as you know.
Of course.
So I will take the microscope. Normally, I don't start with the microscope.
Atul, one pleasantry I'm telling you. So it is Atul, Abhida, Apurva, and Arundhati. See, all starts with A.
Okay, light, please, light on. इसको निकाल. Light on, microscope.
Channel change कर दो भैया once the light is on. वहाँ का माइक्रोस्कोप वाला चैनल. Not this one.
So sharp incision and strong
मैं
incision.
उधर
No,
कंट्रोल में
तो
कौन
ये
है? ओटी में माइक्रोस्कोप वाला चैनल कर दो.
माफ कर रवि. See, little bit, it will look red because of the microscope.
Then yeah,
But-
now we can see.
Okay. Vatsal is there, huh?
Yes, yes.
My dear Vatsal.
Check. So microphone you want to use, they have kept in understand. एक free microphone होना चाहिए.
This is the CT.
भैया. हाँ, thank you. No, no,
Well, good morning.
I know.
The gent is with me. Good morning, sir.
Good morning, good morning. Just a minute, just a minute. Map properly. One second. थोड़ा टेबल ऊपर लो माप नाइस नाइस सेक्शन और फिर ये सेक्शन मेरे को देना बात बोलो
आपका उधर फोकस है.
अभी नहीं है एक सेकंड
Take your time, no problem.
बात बोलो ऑन हाँ now is the image better for you Lucky?
You see, Atul, I think it should get better, but the LED screens.
किस बात का करना है
But he operates in high magnitude. I think it will get better. Once he goes inside.
this is the C2 spinous process okay
Yeah.
can you see the C2 spinous process Lucky?
You know, Atul,
हाँ
the problem is with the LED screens, we don't get that clear image that we used to. Yeah.
see can you see I am in the joint can you see Lucky or no
Yes, yes, we just about saying that we can see the joint opening up.
wait little bit I am not such a comfortable situation Good process. Small figure. See, small figure. See, can you see I have opened the joint, Lucky?
Yes, the right side joint.
Left side.
This is on the left side, okay. Just orient us.
Left side. No, this is not in focus only. What is this? Just a minute, Lucky. I am not in a comfortable situation. Just a minute.
No, take your time.
No, I am not in focus only. Okay, hold me कर दे. Somehow I am not in, अंदर डाल सकते. Yeah, under. Lucky, you have to. Just a minute, my friend. Just a minute. Bone pieces. Bone pieces. Photo. Now, Lucky, can you see or no?
Yes, you just drill the C1, we saw it.
Yeah, now I'm putting bone graft in the joint.
Yeah.
Very good. But ये पढ़ा हुआ है क्या?
Good morning, sir. Atul, sir.
Yeah.
Sir, screen display is not good, sir.
What?
Not able to appreciate.
Now it's better now. Listen.
Slightly better.
Yeah, now it will be better because there was some latency.
Bit better now.
See, I am putting my screw in the C1, okay?
Yeah.
Yes, sir.
Now it is okay. Okay, well, Mota. Very just carefully, okay? बर लगा. Small chisel. Gain it. Help him. Small chisel.
Good morning, sir. Well, sir.
Yeah. Shraddha has come. Oh, full Mota. Shraddha, here I have just started. And
Yes,
just
I've seen from the beginning. Dr. Tripathi
Yeah.
has been very, interactive, and he's asked some very nice questions regarding the imaging and all.
yeah. Full Mota.
Can you tell our delegates over here what exactly are we drilling right now?
Now I am going in the pedicle of C2.
There any trick to identify that?
Yeah, just a minute. Okay, small chisel. See what, this is the lamina. Can you see? Let me show you again. This is the C2 spinous process. This is the lamina. This is the region of pedicle. You see, here is the pedicle. I have just drilled this so that my plate can come here. Okay, small chisel. Let me. Okay, screw. Okay. Do that. Did you see the? See,
Yes.
exactly in 10 minutes we can do this. Okay. I will tighten them a little bit later. Now I want to show you properly the other side.
Yeah.
Did
Please.
you see this side quite reasonably? Huh? Got it.
Yeah, very well. But then some people joined little later, so
Wait,
you can tell them, all of us again.
let me show you the other side now.
Sure.
little bit slowly.
Just if you could just tell for everyone's sake, the landmarks and the point of entry, the direction of drilling and all the rest. You do
Okay,
that by your
Okay,
instinct.
Lucky,
Thank you.
Lucky is,
Yeah.
Samir Somaya from the Somaya Trust is here.
Oh,
And
great.
he will just like to talk to you, to the audience for a few minutes. And
Please.
just a minute, he is coming inside.
Okay. Yeah, let us know when he comes.
Yeah, yeah.
First thing, we have to thank him
Yes,
to have taken you and your team there
yes,
and then provided wonderful facility
yes, yes,
that can make you comfortable.
yes,
And the proof is that this is a workshop. Obviously, you are comfortable.
yes, my friend, yes. Now you see here, this is the C2 spinous process, okay?
Yeah.
Now I will. Okay. Now what I do is subperiosteal dissection. This is subperiosteal dissection. You see this?
Yeah.
Then my job is to expose the pedicle. See,
Right.
here is the pedicle. You see here the pedicle?
C2 pedicle. Yeah.
Then I have to follow the pedicle up to the joint.
Correct.
Now before I
Okay.
do that,
Can we improve the focus?
Atul, right side, remember the artery?
what's that? High riding, yes.
Vertebral.
I will show you after a little while, okay? How I
Yeah.
protect that small chisel.
Correct.
See, that is the key to this operation.
Yeah.
See, I am in the articulation now.
Mm-hmm.
So can we improve the focus?
Yes, just a minute, just a minute. Just a minute. Yes. Now, Lucky,
Yeah.
Samir Somaya, he's,
Okay.
he's the chief trustee of this hospital and of
Excellent.
many other institutions in the city and elsewhere in the country. So he has
Very
given
good.
me this opportunity to work here with him in this hospital.
Yeah.
And he has made this setup. So I will like to first you to welcome him. Dr. Lucky
Yes,
Tripathi
yes.
is the very senior neurosurgeon from Calcutta. Samir, Lucky Tripathi.
Samiji, namaskar. Namaskar from all of us in the auditorium, Golconda Auditorium in Trident. And first thing is that we really appreciate your contribution to the society by building this and many other institutions. And also we are very thankful, all of us, because we are friends of Professor Goel, that you could provide him and his team the facilities and all the necessities that he needs to run a world-class neurosurgical unit that he always, continues to do so throughout his career. So we welcome you and thank you for all that. And God bless you and your institute and your team. Thank you, sir.
Thank you very much. I just wanted to say that neurosurgery is personal for me. My father was for 2 weeks in a neuro ward, so I am very, I have sort of experienced it in as a person understanding what is happening in the neuro ward, and I always thought that I will do my best effort to work towards creating a world-class neuro center from all the way from emergency to rehabilitation. So I'm very happy that Dr. Goyal and the whole team is here helping us. So thank you very much.
Thank you, sir. And we also take this opportunity to thank the audio-visual connections that we are beautifully seeing it here from both sides. And a small request from all of us, please make him and his team comfortable so that they never leave as long as we all survive. So you know what I'm saying, because I'm also a senior vice chairman of a hospital group. So I understand the other side of the story. So
Okay.
Thank you very much. All the very best. Bye-bye. Namaskar.
Thank you. Screen पे बर लगा बर.
तो व्यू चेंज करा दो भाई. हाँ, वो वाला लगा दीजिए.
Okay,
PIP का वो.
okay,
not
Lucky,
that.
can you see now again?
Yes.
So this is C2 spinous process. You see,
Yeah.
it is because I stabilized the other side, it is quite stable
Yeah,
now.
looks stable now. Yes, quite right.
See here, this is the pedicle. You see the pedicle?
C2 pedicle, yes.
And here, you see this will, here, I have to be careful about the vertebral artery as I have mentioned to you.
Mhm.
So once I see the pedicle, my direction of the screw will be in this side, here, not in
Right.
this side, not
Ah.
from here. It has to
Okay.
be from here and going up like that.
So you have to miss the artery. Yeah.
We have to miss the artery, otherwise we'll have to miss the patient.
No. So your contribution, this surgery is immensely important for all of us, and your experience tells us.
So I'm little bit drilling this pedicle and drilling little bit of the lamina.
Yeah.
एक receptor जो है, this process. See, now what I'm going to do is, you see, I'm going to follow the pedicle inside the articulation. Small
Okay.
children. Stop now. You see the articulation there?
Yes.
Small children. Okay. See, this is the most difficult part of the operation actually,
Of course.
to get into the articulation. But if you follow
Yeah.
okay, Venus to Venus. Stop now. You see the C1, C2 joint?
Yes.
See now the facet. This is C1 facet.
Hmm.
Venus, hole maker. See, this is C1 facet.
Yeah.
I am making a hole in the C1 facet,
Yeah.
right in the middle and right up, and little bit medially. You see this?
Okay. Yeah.
So I made a hole in the facet C1. Now I will put some bone graft in the articulation.
Hmm.
And putting a bone graft in the articulation is very, very critically important for fusion.
Yeah.
You know, this putting a bone graft was described in 1988. Can you believe that, Lucky?
Yeah.
Now, screw, plate and screw. You know the chisel. Dr. Ravi is assisting me, Lucky,
Okay.
and he has assisted me in several cases. And
Oh, yeah.
every time I complete the operation, I say the patient is cured. And he has been
Yes.
witness to several of these.
I'm sure. All of us have witnessed that.
Gel form. Now, as I have told you, this small figure. It is very critical to direct the screw very nicely and medially and superiorly. You see, it should not go laterally. It should not go, you see, this is the pedicle here.
Hmm.
So it is, I have to go direct it medially, okay?
Hmm.
Medially and rostrally.
Okay.
Can you see that?
Yes, yes. Very different direction.
Very superior and medial. Small
Superior
figure,
medium.
small figure. Okay, three guys. Can you see that this operation can be finished in half an hour, Lucky?
I know that. Many of us know that already. But yes, people who are watching you for the first time, it is like a impossible.
And I can only tell you
Hmm.
that this patient is cured and cured like a magic. And also, not only cured, this patient has got a new life.
Yeah.
And that new life will be instant and immediately after operation. So what I have planned is to show you videos before operation and after operation in the evening of the operation.
Yeah.
And you see how tight and strong it is, this one.
Yeah.
And without any question, this atlantoaxial instability. And if you realize that I have not used any coagulation or any kind of costly or monopolar or bipolar, then
No.
I sometimes use some little bit costly here and there, but not too much. See,
Yeah.
majority of bleeding in this area is venous.
Hmm. Just half an hour when you started, since you started. No?
So lucky,
Yeah.
whilst I am about to close this now,
Hmm. You remember the very disabled boy you operated in Calcutta?
what's that?
A very disabled boy came in a wheelchair, called up with a CV junction. You fixed
Yes, yes,
it.
yes, yes.
He's improving, you know. Very disabled, and
No,
in
no,
fact, when I saw the child for first time, I said, "No way, we cannot operate." But then you agreed.
see this operation, lucky,
Yeah.
this operation is so important in our subject. And the indications are now rapidly increasing.
Hmm.
My feeling is all the young people have to learn this operation. And there is no question that, in neurosurgery, nobody can say, I don't want to learn this operation. Small needle.
Yeah.
See, now what I'm doing is I am removing all the muscles of the C2 spinous process. Can you see
Yeah.
that?
Yes.
It is very important. The muscles are so strong that if you do not remove these muscles will pull away the implant.
Hmm.
That is the problem with anterior surgery. When you do anterior fixation, you
Yeah.
are not doing anything to these muscles.
And the
these
tension bands.
and these
Tension
muscles
bands.
will not spare. These muscles are so strong that
Okay.
they will just take away the.
Implants.
See, I am now drilling the entire structure. Ready? See, I am making this bone suitable for the bone graft.
Yeah.
So. Nice. Just to, Mr. Samir Samay is still here.
Okay.
Lucky, I will just let you know about his various charitable organizations that he runs. And not only charitable, but also teaching institution. There is a big
Yeah.
Ayurveda hospital just by the side of this hospital.
Okay.
There is a medical college attached to this hospital. Quite a big
Yeah,
medical college.
You told
From
me, yeah.
where
Very
Dr.
good.
Abida was trained.
Okay.
And,
Yes.
you know, it's a complete bonga. He is so many, Samir, would you like to tell them about your various activities? No, just let them know because I am now closing. It is done, the main thing.
Yeah, it will be very interesting to, of course, the contributions of people like Mr. Somaya are very important for our society. And
Completely.
the government is not going to do much more than is already doing for health sector. So we need a lot of enterprising people like him. Yes, please.
So my grandfather, can you hear me?
Yes, yes, sir.
No, my grandfather started business in 1939. So he started with a small school in rural Maharashtra in 1942.
Mhm.
His,
So the
yeah.
sorry, just a second, Mr. Somaya. We want to see you because Professor Goyal is closing. Atul is okay.
Yeah.
So when you are closing, we can
Yeah, just,
see Mr.
here, go ahead, Samir.
No. Atul,
Just a minute.
did you release the traction? That's what.
No traction release, nothing. I have not
No,
touched it.
the traction which was there earlier.
No, traction I have not touched, Lucky.
Okay,
Yes,
thanks. We'd like to hear Mr. Somaya continue.
yes, just now.
No, my grandfather was, he was born in 1902 and was born in very difficult circumstances. I think he lost
Right.
his mother when he was 3 or 4, and he lost his first wife to meningitis within the first year of marriage. And,
Sorry.
he didn't have too much, it was a time, and neither did he have the resources to, I will say, take care of education or health in his family. So in fact, when my father was born, for the first 8 months, he didn't have money to buy a train ticket to go see his son, firstborn. But 1939, he started business. He was very successful in sugar. And then 1942, he established a school in rural Maharashtra. And from then the journey, as he said, of giving back to society started. And 1959, he established higher education in Mumbai. And then the
Right.
journey of school education, vocational education, and higher education continued. And in the 1980s, he established the KJ Somaya Medical College. And he was very keen, in the 90s, early 90s. And he was very keen that the effort should be on rural development, tribal care, and also in urban and rural education and healthcare. So that journey continues. And the dream for us today is to create a world-class center for teaching, research, and service for all segments of society, those who cannot afford it and those who can, and also to do top quality research and cutting edge healthcare. And across, he called this campus Somaya Ayur Vihar. Vihar means oasis and Ayu means for health. So that's what was this campus. The other campus was called Vidya Vihar, and an oasis for education. So this is the dream, and I'm very happy that, as I said, for neurosurgery, neurology, and neuro care, there is a personal commitment, and also for emergency care, because my father was in Australia when he had an accident and a head injury. And so
Oh.
with that, we built a very nice emergency downstairs, and it was always my dream to also do similar work for the neurosciences and neurocare. So when Dr. Abida approached me only a year ago, I was
Uh-huh.
immediately ready to help, and the whole team is here, and Dr. Goyal is very much helping us take this dream. He said it is also his dream, so we are saying 1 + 1 can become 11. So that is the whole idea.
Oh,
So
yeah.
thank you very
It
much
changed.
to, yeah.
No,
Yeah.
no, thank you so much, sir. And I think what we would like to do this next year, we like to be in your place seeing this surgery in the auditorium. I think that will be probably, Atul, you agree?
Yes,
That,
yes. Next year we'll do it here in Somaya instead of
Yes,
Trident,
yes,
where you are sitting now. Next year,
that's
we
right.
would like to do it in the auditorium in Somaya.
We will be
Yeah.
delighted.
Thank you, thank you.
Thank you so much.
Thank you, sir. Thank you, sir.
Thank you for the service you all do for society.
You're welcome, sir.
It's coming in the evening.
Lakshmi,
Thanks.
we will like Suresh Nair to say some few words because
Of course.
uh,
Just hang on a second. Yeah, there it.
Dr. Nair is the
I
Dean
was-
of Sri Chitra Medical College.
No, whole time. So that's the past only. So Atul, I learned something from you. I didn't realize you have to remove that muscle attached to that C2 spinous process for a very good fixation. That was a learning thing for me. Because the first time you were telling that all the muscles have to be cut and removed.
No, he tells her always.
Yeah.
You must
But,
might have missed.
and then one thing I am curious is, so you have applied some traction in the beginning. So I was just wondering, at what point of time you will release that traction?
I will release it as soon as the operation is finished.
But can you do it intra-op after you have, just before putting the, or after you have fixed the screws?
After I fix the screws, I can do it, but I don't want to disturb my setup at this time.
Oh, okay, Atul. Lovely, great, and you promised you will fix it in half an hour, and you have done that. Great. Okay. Okay.
Dr. Nair, just say a few words about the institution, and Mr. Somaya is here. Just convey your regards to him.
Yeah. Actually, I was just listening to you, and please continue this great work. Samir, you're Samir Somaya, no? So great work at your institution. I want to come and see that place. If I am coming there tomorrow.
Oh, you are
So
coming
that-
here tomorrow? So please come.
Tomorrow we'll be there. Yeah.
Coming to see your institute, please see that somebody takes us around. Your all places, departments and all.
Thank you.
Tomorrow being Sunday, I'm sure many people may not come. But of course, we all would love to see the place.
Thank you so much.
Okay, thank you, sir. We hope to see you in the evening.
No, my daughter's birthday today. She's turning 15. And we have only a group of 6 of us celebrating her birthday, a family, not her. She still wants to celebrate with her family right now. I hope she continues to do so. But so,
Okay, please enjoy that.
yes,
Happy
please
birthday to her.
excuse me this evening. Thank you.
Okay, thank you for
I
addressing.
told
us.
Dr. Abida on day 1, 8 July, difficult for me, even morning, but I have run away right
Yeah.
now from her. And
Yeah.
but
So
evening I cannot, I don't want to escape.
So convey our birthday wishes to your daughter.
I will. Thank you so
Yeah.
much. Thank you.
Okay, thank you.
So what is happening in the next theater, Atul?
Yes, now next case, I am going to show you a beautiful different strategy. Yes, just a minute, Lucky. I will move
Yeah.
to that side now.
So that is also Goel's lumbar fixation, no?
Yes, you will see.
I know. That lady who operated in Calcutta, I saw her, she says, I have no pain at all.
Yeah. I will show you the magic show now. Okay.
Mhm.
You see, Lucky, the whole thing can be finished right from skin to skin, from bone
Yeah.
graft, to the entire operation in quick time. Basically, one has to be very familiar with the whole story.
Correct.
And also, you know what, as I mentioned to you, this operation is so important in giving a new life to the patient. There is no question that. But I am happy to say that this surgery in India is much more advanced than this surgery is in US. Can you believe that?
Amazing.
There is
Yeah.
no question that there is craniovertebral junction surgery is the most advanced in India than anywhere else in the world. So I
That's
think,
partly due to your contribution as well. So, and there are so many other people also, sort of leading this in addition to yours original one.
yeah, of course, of course. But whatever said and done, if you talk about any surgery, like you talk of hernia surgery, you talk of appendix surgery, you talk of this fellow's technique and that fellow's technique, but
Yeah,
you
India is
talk
doing
of
well.
craniovertebral junction, you talk of nobody else's technique. That is the beauty.
We know that.
Atul, just want to ask from your experience, what are the chances of implant failure?
I can tell you, Suresh, and I can tell you with complete, I have done more than 3,500 such cases. I have
Yeah.
never reoperated a case, never. I have
By the
never
time bony fusion will take place, no?
fusion,
Bony
you see,
fusion,
what is the most important is bone fusion. If the bone fuses,
Yeah.
you see
Yeah.
the implant will hold the
Yeah.
region for 2 months, and then
Yeah.
bone will hold the implant.
yeah,
First,
okay.
implant will hold the bone, and
Yeah.
after 2 months, implant has no role.
Absolutely correct, yeah.
And you know what? Most important is what I put in the joint, this intra-articular bone. That is a very important place
Yes,
for
sir.
bone fusion. And when you put that implant, that is the site of movement. That is the fulcrum point or the pivotal point of movement of the joint.
Okay.
So
Some
now,
mattress sutures and other things are not mattress. I thought all we are putting mattress.
see, I have,
Yeah.
one thing I have done is in this operation, if you have realized that I have not used pottery at all. But it is not always, sometimes I use, that is not the key thing. But of course, I don't like to use monopolar and all those things. Now, Suresh,
Yeah,
Uh,
Atul, just one thing. Are you, I think by personally, from what I have seen, you are a left-hander, no? Rian Lara,
Is
no, actually,
Happy-
I'm not.
ambidextrous.
ambidextrous, or are you a really left-hander?
No, I'm not.
Now it looks you are a right-hander, but you hold the section in right hand. Cork is KEM technique only, section in right-handers, they hold section in left hand. So I see you holding it with the right hand, because that is your dissecting instrument also, no? Probably because of.
I will show you in the next case, I will show you in a tumor. In a petroclival, there is a next case is a petroclival meningioma actually. In that,
Yeah.
I will like to show you the technique of using right hand.
Yeah. But your sutures, you are putting, you are a right-hander.
Mm. Yeah, this is right hand.
Dr. Dev Pujari is also here, Suresh. in the operating
Yeah, yeah.
theater.
Wow.
Big post, yeah.
Theater.
Big post,
Good morning.
yeah.
Give him
Good
the
morning.
microphone.
I seriously
morning.
didn't realize that we were supposed to meet in Trident this morning, so I reached here and I had the
Oh.
good fortune to see the actual surgery.
So we-
Yeah, you were lucky.
But probably, we have seen it very well from the auditorium.
But you don't get the feel. The operation
Yes,
theater
yes.
is really nice. You can watch the
Yeah.
greenery outside as well from the windows, apart from the
Yeah.
good surgery, which you can't watch that from your monitors.
The ambience. Yeah, we can see you now.
Here, if your bladder is full, you can go out. There you cannot go out, no. You have to hold on with.
I'll see you guys later.
Okay. Okay, nice to see you. Thank you.
Okay, now.
Yeah, wherever he goes, he is an inspiration, Dr. Dev Pujari. So,
Yeah.
yeah. You are an inspiration to the younger, trainees, especially to all of us.
Thanks, Lucky.
I have to only tell you that this lady has got a new life. You show pre-operative video and post-operative video to him today, not today, tomorrow.
It's a
You will see the magic.
they will take down to see whether it's
This
reduced
surgery
or not.
has
X-ray. No X-ray.
lot of thought
He
process
put
has
that
gone
image in the cloud
Up
set,
now.
so that he can show everybody.
It doesn't take X-ray. Yeah. Oops.
No, we want to make it a bigger center and I will like to have his services also. Dr. Dev Pujari is in Bombay Hospital. Very senior, so I will like him to be involved with our project.
We will also appeal to Mr. Somaya that do everything he can to make this a world-class center. He is already in the process, and I'm sure it will be bigger and bigger every year.
I will say so far, whatever Abeda has said, I don't know if they know you, Abeda. They know you. So far, whatever Abeda ने कहा है, बैठो तो बैठा हूँ, उठाओ तो उठाऊं. Any for the Gujaratis in the audience, उठ बैस कर हाँ, उठ. आणि मराठीमध्ये म्हणतात उठा बसा. हा.
He is also known internationally.
Yeah, absolutely. Who doesn't know Abida?
Right,
And
she just came to our office a year ago, I think. Yes.
So she is a proud alumnus of your institute.
Yeah.
Yes. We're delighted to have her back.
Yeah.
Yeah, she is more than happy. We always share things between ourselves. He is more than happy to be back there.
She is the bridge between us and Atul.
Yeah,
No.
absolutely. So many years.
No, Big Boss doesn't open on WhatsApp and all.
See the other side.
Yeah. He doesn't have this WhatsApp.
कोई बात नहीं, अच्छा हुआ कोई बात नहीं ये लंबर के साथ क्यों फिर तो वहाँ अच्छा है
Atul,
Now I will start here. This is here almost 7 pictures.
Atul,
So he is now ready. I'm going to start in now. Yes. मेरा गाउन खोलना है क्या? गाउन खोल के मैं दूसरा गाउन
Too many people have come.
Yeah, Abida. Can you hear us, Abida? Atul?
एक मिनट.
वो microphone off हो गया क्या?
नहीं.
इसको मानना है इसको
I want Atul to be online all the time, if possible.
Lucky, you can hear me now?
Yeah, please keep on talking. We don't want to lose you. So what is the next case you are doing? And
We didn't see your anesthetist,
yes,
very important person. Line got cut.
no. Whether they can hear us. I think they're planning the next case in the next theater. Anyone has any questions to Professor Goel from the audience on this case? Please volunteer, you can ask him. How many people in the audience are seeing him operating for the first time? Atul, yeah. How many people? First time seeing him live? 4, 5, 6, 7. Okay. 8. Good.
अरे इनको कैमरा उधर लगाने के बोल इस पे माइक पे इस पे
You want to, yeah. Atul? That is on, but I don't know whether he can hear us. Oh,
Hello.
जा रहा क्या उधर sound? जा रहा ना?
Sir, I want to ask a question.
Hang in, whether Atul, he might not be. So he's going to show the next case.
Yeah, that's the question. Let us see whether.
We'll ask it. We'll ask.
Tricks to prevent whatever likely injury.
You saw the technique, direction of drilling and point of entry and.
And once it starts bleeding, what to the continuous bleeding. Then it will stop. You will keep on doing.
What else? You can't do much.
Hello.
I think
This is something.
no one does intraoperative angiogram to save the artery. No one, to my knowledge, so. It's difficult to imitate the master, but there's so many people doing Shivanti too. Yeah, this is a lumbar case.
Hello, Tripathi sir, hello.
Hi, Apurva.
Hello,
Yes. Can you hear us?
hello.
Apurva. ये ऑडियो चैनल कुछ गड़बड़ है यार. डिस्कनेक्ट हो गया, 2 वे नहीं हो रहा है.
Can you hear Apurva?
हाँ.
Apurva?
Spirit system.
5S1.
L5
Atul.
Apurva, can you hear us?
नहीं वो माइक चालू नहीं है.
Apurva?
Hello.
Yes,
Yeah, we can
Atul.
hear you.
Yeah, so she is a 56-year-old female. She is suffering from low back pain since the last 2 years, which has worsened over the past 6 months. She has severe right radiculopathy and a severe claudication time of 10 minutes, no gallbladder involvement, and she has severe tingling and paresthesia below the knee and especially over the soles.
Apurva,
Yes, sir.
is she obese or something?
So she is a short-heighted female, not very obese.
Okay. Yeah. Yeah. Yeah, the 5S1. Okay. Okay.
To touch this disc, I'm just going to do stabilization of the spinal segments under vision. So I want you to see this operation. I have recorded the patient's clinical story, which I will like to show you in the evening. And I will also record a video of the patient, which I will show you in the evening. So here is the
So,
patient.
Atul,
Yeah,
there is a large fragment on the left side
yeah.
and causing the pain. So your technique by fixing will decompress that root without doing any discectomies, correct?
Yeah, so my concept is compression is not the issue and decompression is not the treatment. Instability, vertical, which I will probably like to speak in the evening in the CME.
Sure.
Vertical instability is the issue, weakness of the back muscle is the issue, and instability is the issue. So now the thing is, the patient is in front of you, the operation is being done in front of your eyes, and I will like to show you the result in the evening of operation, okay?
Okay.
So let's begin with.
Any-
So
Any deficits she has, Apurva?
any deficit? There are no deficits. So,
Okay.
so I'm beginning the operation. Let us,
Next one, next.
Sister, come. Mop.
Hello, Apurva. Hello, Apurva.
Good person. Good person. No, no. Cut. Yeah, again.
So Atul,
Yeah,
nowadays, many of us are going the MISS way in the spine, minimally invasive spine surgery, where basically we try to protect the muscles. But since you are advocating or your concept is that the
So-
muscles are
lucky this is
adding to the
a,
instability.
the concept with, when you do minimal invasive,
Yeah.
the concept is to do minimal invasive to do decompression. So
Also fixation.
I'm not doing any kind of decompression. You will see this.
No, I was talking about fixation.
Yeah, fixation, we can do minimal invasive, no problem. It's okay. But I am doing a different kind of fixation that you would
Correct.
like to see. I am going to do
Sure.
fixation at the fulcrum of movement, and that is at the facet.
Perfect.
And you will see how simple it is, and you will see how strong it is.
Yeah.
Just give me some time to expose, then I will talk to you about this.
So most of us do pedicular screw fixations.
Now you will
know?
see a different kind of fixation. Nice.
Yeah, so is it the
Nice.
same stabilization process or different?
See,
To your-
pedicles are
to your-
pedicles and facets are facets.
Correct.
So here I am not doing pedicle fixation at all.
No,
But ultimately it is the vertebral segmental fixation
okay.
eventually. Isso retractar, master. So I will take the microscope now.
Okay.
क्या कर रहे हैं? चल ले. Okay, perfect. Take the microscope. Let us see, Lucky. I hope you can see the image.
Yeah, microscope
Wait, wait.
channel थोड़ा change कर दो भैया.
Just a minute, just a minute. This customer is not constant. Okay, take the microscope. Chalo. बीच से रखा ना, बीच से. नहीं, बीच से इधर नहीं. Yeah. हाँ, अभी take the whole microscope here. Go behind, go behind. Go behind, go behind, go behind. Now you have to tell me, Lucky, if you can see it or no.
We see something, but not in focus.
Wait. इसका निकाल बीच में से.
Do you have Leica microscope on both sides or only
No,
this side?
This is Leica, that one was right.
Okay, a bit like us.
Can you just, I'll focus, you have to.
Getting better.
Can you see, Lucky?
Yeah.
Section. Then you can give my section, this is it. Okay, go next to the name. Okay, now let us do this case, okay? Then आवाज थिएटर में बंद करें. Okay, to start up a nice. Now. How? How? Lucky, can you see?
The focus is not great, but
That focus.
you are
Huh?
exposing the facet joint.
इधर. Okay. देख तो फिर कौन सा माप बोल रहा है? ये?
Would you check the level, Atul, with X-ray?
Yeah, I will, you know, here Good person. See, first, let me show you the unstable spine, okay?
Okay.
Okay, that will neglect. I have not heard. Can you see, Lucky?
Yes.
Just noise, please. No noise in the theater, please. Now, Lucky, just carefully see. Shekhar is
Oh.
there?
Yeah.
Shekhar?
Where?
Now you see
In
this
theater.
unstable. Can you see the
He's
unstable?
alive? Not yet.
Devpujari kahan hai? Dr. Devpujari?
Dr. Dev Pujari must be there, or I don't know. He hasn't arrived yet.
Can you see the marked instability, Lucky?
Yes. It is moving.
Moving like anything. You see, this one is also unstable. You see here,
So what levels?
this is L45. This is, I am going to check that again, but there is a marker here at L45 level. This is L45.
Please check X-ray, na? Please check X-ray, na?
See the unstable. You see the beautiful unstable. You see this?
Okay. Okay.
Okay. Keep for a second now. Remember. Okay, okay. I was second. Okay. Forward.
So, Atul,
Yeah.
see, instability in everybody's understanding is you do a dynamic X-ray and you say instability, no?
You know what, Lucky?
Yeah.
I suggest you just see the operation. We will talk
Okay.
about the concept in the evening, okay?
No problem.
I have to give a lecture in the evening. So I will talk about
Okay.
why I am doing and what I am doing, okay?
No problem.
Let us now at this point of time concentrate on what we are doing. Because this is not in focus, Nilesh. Nilesh kahan gaya? Focus pe nahi hai. इसको लेंस को क्लीन कर यहाँ से. That will निकला. You are seeing, Shekhar, let me show you. I wanted to show you. Now you see just, abhi tu dekh abhi, just dekh. That will nibla. Just see how much unstable it is. You see this? You see how much unstable? You see this here? They are completely unstable. It needs only one thing, and that is stabilization.
Yeah.
Here.
The focus is not great, but we are kind of guessing.
Wait, my friend, wait. This is L4.
Yeah, many from the audience is requesting
Yeah.
whether
See, this is the articulation here, this one. That will neglect. That will neglect. Whole maker. Now you see here, Lucky, this one. You see this?
yes.
You see
So
this? La, whole maker.
which is left, which is right? Just orient us again. Atul,
Yeah.
which is left?
This is right side.
That's right side. Okay. So you are drilling on the inferior facet or superior facet?
This
Because
is
you can't really see.
the facet.
Yeah, which one?
That's been neglected. Stop.
You won't need X-ray, Atul?
What's that?
X-ray?
No,
Siam?
no X-ray, my friend, no X-ray. Right, sir, sir. ये परसे पे ना ना how much?
So we are unable to see anything properly.
ये लेंस क्लीन कर जरा मेरा. See, this is the. Can you see now?
So it's
See,
out
this
of
is the
focus.
spinous process. This is
Yeah.
this is the
Fixed
articulation.
joint.
That will let me show you the articulation again. Okay.
Mhm.
So the joint is out of focus.
You see the joint?
No, we cannot.
Wait. I'm just removing the spinous process. Hmm. Too much. No. Oh, that will be. Okay. That's it. Shraddha, can you see it or no?
No, sir, can we focus in the depth, please?
Just a minute, yeah.
इससे ज्यादा नहीं दिखेगा I think.
See, I have done a transfacetal fixation, okay, transarticular fixation. Question.
If it put two screws,
Just see this now. Sister, give me screw. Screw. So here is my screw, which is a transarticular. This is 18 millimeter screw.
what diameter?
This is 2.6 millimeter diameter.
2.6.
So what is the direction of the screws?
This is direction is transfacetal. You see transfacetal. Now, if you see, this is completely like a rock now. Can you see that? I'm not sure if you can appreciate it properly, but I can see it very beautifully. That this is no, zoom is lowest. Okay. Second. See, here is the, you see, here is the joint, here. Can you see the joint? Shraddha?
Yeah, barely.
Yeah.
Yeah, I mean, I can see, but.
Yeah.
Hmm. So your direction is lateral
Lateral and under vision.
and anteriorly under vision. So you see the, yeah,
And downstairs, you see down, not
down.
too much lateral. And if you realize that I don't need to do any imaging or C-arm or anything.
So will you take one after completing?
Was that?
One X-ray after you finish fixation?
Yeah, maybe if you are saying I will do it, but normally I don't do.
Please, Atul, because
Yeah.
you know, I'm sure you're absolutely right. Just for documentation
No, we'll do it. We'll do it.
and for everyone else to see.
C-arm ready, Ragna.
So both the screws are on the posterior facet, which is the superior facet of S1, correct?
Yes.
And they are going across the facet joint to the anterior L5 facet, which is the
Yes.
inferior facet of L5, correct?
Yes, this is completely a solid fixation. Solid means solid. I will talk about this in the evening. Why this fixation
Sure.
and why fixation? Why fixation and why this fixation?
Atul,
Yeah.
in this joint, you don't put any grafts, no?
No, here I have not put any graph, but I have taken the spinous process and that I will use as a graph later. You will see.
Oh,
See, this is directly under vision.
okay.
Let me show you the other one now. Now that you have got an idea, I will show you the other joint. See, this one is like a rock now, this one. It is not going to move. Now I will use this one, L5S1, okay?
So this was L45.
Yes. I only hope you can see it now. Let us see. Okay. Give me another reflector. This is a little bit clear.
Atul, I think we have to do something for the LED screen clarity.
What's that?
The LED screens, no, that we are seeing here,
Hmm.
the pictures are not crystal clear, unlike the older screens.
It's perfect now. It's perfect now.
It always feels that it is out of focus.
No. Now the Leica expert is here. I'm going to tell him.
I don't think it is with the microscope. Remember, we had the same problem in Calcutta.
Cut.
I think he will tell you about the working distance, that is not.
Give me that. Stop. Picture up. It's perfect now. Picture up, inside. Now. Pull it up. Pull it up. Forward. Pull it up. No. Here is the joint. Can you see the lucky joint or no? I'm not sure I can show
It's
you.
the
that.
same problem, the focus thing is a problem.
Wi-Fi is not.
It's a problem of the LED screen. I know it.
The frames are missing, it is the jerky movement, not a smooth movement.
That is from the net.
Okay, hold me कर दे. Hold me कर दे. Duckbill nibbler से. इसके जरा क्या करना फिर हाँ. Okay. hold me कर दे.
Yes, you can, but not go to theater.
क्या सदा
Yes, sir.
हाँ.
Yes, sir.
अभी now I can hear your voice at least nicely.
I wish we could see the image that nicely. It's better than before, but
Let us see now, Sadda. Nice.
so you're again going to remove the spinous process here also.
Let us see if I have to ultimately use it as a graph, so I am going to remove it. if my diet, particularly during the screw, you see here is the articulation. Can you see? Just a minute. Now see it properly, okay?
Yeah.
See, this is the articulation here. You see this?
Can you insert a dissector or something and show us? It's
Just
not
give me
very
a
clear.
small duckbill nibbler. Now I will show you by moving this. You see here? Okay,
Yeah.
hold me, hold me. Stop, sister. Stop.
Do you always like to use two screws? Is one screw isn't enough for the fixation?
Sometimes I use even 3 screws.
Any specific reason for that?
No, just to give, I call it double insurance or triple insurance screw. You see, 2 is better than 3 or 1 is better, 2 is better than 1.
You think it is more important in the lumbar spine because of the weight bearing to put
Yeah,
more
the
screws
lumbar
in the
spine I
facet?
use more screws because you have space also here. So this double insurance or triple insurance screws are, you know. Okay. I can tell you one thing. This patient, I want to get a video in the evening and show you. You see here, I have not done any decompression. And I want you to see. This is a brand new concept. This concept, I am telling you, this is here to stay. There is no question about it. This concept is here to stay. And I'm showing you this one case. I had one cervical also. Unfortunately, that fellow didn't turn up. Don't push, just turn. Okay, okay. Now show here. Through, okay.
So you are using this technique in degenerative spines, single disc prolapse also?
Yes, in a large number of cases. In the evening, I am going to discuss about those philosophical things in the evening. Now is the time to see this technique of transfacetal fixation. And I want you to see how strong it is. Most important is it is at the fulcrum of movement. All the movements occur at the facet.
So Dr. Nair is asking how many levels, is it an intraoperative decision or
Yes.
we decide beforehand?
That is also very, very interesting and important question. Very important question. So it is on the basis of, you see, when there is canal stenosis, when there is claudication pain, it is not one level instability, it is multi-segmental instability, even if it is not shown on the imaging. So here I am going to do three levels. Now you see here, you see how firmly it is stable. You see here, completely like a rock. चल ऊपर ले no. Perfect and big nice. How much? Can you see the articulation, Shraddha?
Yes,
Yeah,
yes,
roughly, yes.
better now.
Not very clear, but roughly, yes.
That is little bit you see, that is enough. See, this is the articulation here. The whole metal.
Is this also mobile? Can you show us the mobility?
Yeah, it is very mobile. That will be good. See here now. But it is not as mobile as the lower one. You see this? Can you see?
Yes, yes.
Yeah,
Very highly mobile actually. The whole metal.
So since this is the facet joint, obviously there is going to be some movement
Yes.
normally also. So
Okay.
how do you recognize that this is hypermobile? Right, you know,
That you have to use some of your experience also in that. I can tell you one thing. For lumbar canal stenosis, I am using this technique for last at least 10 years or 12 years. Not one patient I have reoperated, not one. Well, it's capped, it's a cap. Second. This person now. Oh, oh. Normally, you know what, the movements will be not as brisk as they are here.
yeah,
Normally, in the normal joint, I will show you upper one, I am not going to do. But I'll show you that between normal and abnormal. So,
Yeah.
so,
Atul,
yeah,
just tell the microscope chap, no, to work on the clarity of images for the next case.
no, I didn't hear Lucky what you said.
The images, what we are getting on the screen, they are not very sharp. And there is a suggestion from the audience that whether a microscope,
Yeah, okay. Let us see, I will ask this.
yeah,
The
just
master,
ask the technicians.
the master of Leica is here with me,
Very good.
and he will give some solution. Let us see what solution he gives.
Okay.
Yes, that's it.
But what
Three
is, how
focus.
is the image there in the theater?
Image looks quite clear to me here.
In the theater, okay, so.
That-
He is focusing. He is focusing, that's why he is able to see, no, otherwise. So the cameraman there, whether he can focus on the screen there with the camera rather than through the microscope.
Let us see, I am almost finishing this case, maybe for the next,
Yeah, I'm sorry to disturb you, Atul, but
case, maybe he can do it.
yeah. Because people are not enjoying, as much as they should.
Yeah, I'm doing.
Not as much as,
They should.
Reduces magnetism of body.
all those technical things.
Lucky, can you hear me?
Yeah,
See, I never used to talk about spine in my life, in my career, in subaxial spine. But now I can tell you, but circle mark. I'm not sure, Lucky, if you have seen or not seen,
we saw the screws
but
and,
this is like a rock now here.
okay,
It's a double layer. Now I will use some bone graft, okay?
Okay.
And bone graft I take from the spinous process here.
Hmm.
Take this one. So essentially, the aim of operation is fixation, and the ultimate aim of operation is arthrodesis of the segment. Hmm. Hmm. Double needle struggle. Double. इससे ये केक मार सकते हैं इधर के लिए लगेगा मुझे.
Is it essential to put this bone graft?
Yeah. It is essential because we are aiming at ultimate arthrodesis of the segment. You see, I told you, no screw can last more than 2 months. So the screws will hold the implant for 2 months. And after that, bone graft will hold the implant, not the implant. Okay, bone graft. Then you see the bone graft here?
Yeah.
So if you have realized that even in this operation, there was no coagulation at all. Did you realize that?
Yes, yes.
There is no coagulation, there is no gel foam, there is no surgicel, there is no drain. Hmm. Problem is, if you cannot see properly, it is a little difficult for me. Hmm? क्या उधर क्यों नहीं दिख रहा? अच्छा. मोहन उधर नहीं दिख रहा बोल रहे. हाँ, बिकॉज मेरा तो इधर एकदम क्लियर है.
Yeah. So now since you are closing,
हाँ,
we can see the fat and skin properly, but the thing is that the important part of the surgery, like you were trying to show us the facet joint, it was not very clear, I must say. That's what most people here in the audience also were saying. So we were wondering about the petroclival meningioma case, because that we need to see everything clearly,
Yes, let us see, my friend.
whether the microscope people can work on it.
Okay. Okay, so we will move on to the petroclival thing.
Okay.
कल इसके बाद में करें। मेरा माइक जा रहा है, अभी आवाज जा रही है क्या देख?
Yes, sir.
ओके, हाँ पैर ऊपर लो पैर। ओके बस पूरा टेबल ऊपर जाना।
Are you taking a Siam shoot? Sir, can you hear us?
Hello? Hello?
Can you hear us, sir?
Yeah. So tell me.
Are we going on to the next case now?
Yes, petroclival meningioma. Let me show you the images. This is a relatively straightforward tumor actually. Nothing too great about it. This is, you know what, can you hear me?
Yeah.
We cannot see
Atul,
the image, but
let us have the camera on the images,
Yeah.
please.
The petrous meningioma skirting around the internal aortic canal and meatus. Little bit tumor is.
Can't see anything.
and the
Yeah. And attached to the petrous apex and the tentorium. I will say.
sir, we can't see here on the screen. Just a moment. Yeah. No,
No?
we can't see. We can't see.
ये दिखा ना ये वाला
So show us on the scan.
दिख रहा है अभी?
Yeah.
Yes.
So this is a petrous apex meningioma. I will say it may not be even petroclival because it looks like under the fifth nerve, not medial to the fifth nerve. And this is attached to the tentorium quite widely and attached to the petrous apex and tentorium. Tentorium का दिखा जरा रवि. So in the
MRI is there also.
Yes.
Okay.
It's a glove.
Okay, can we see the T2 weighted images?
You know what? I can tell you, can you hear me?
Yeah.
See, this kind of petrous meningioma, even today, many people in the world are doing middle fossa approach for this tumor.
Yes.
Not some people, many people. This is little bit, not so formidable, but every tumor is formidable as we know. The issue in this case would be identifying and saving the 7th, 8th nerve complex. And also, otherwise, I don't think there is too much in this case. 6th will be medial. So here in this case, it is not going very medial. So the 6th nerve is rather safe in this case. In petroclival meningioma, that is the main issue of the 6th nerve. But here,
Yeah.
because it is little bit lateral to the clavus, that nerve will be a little bit better. Travel. So I'm going to show you a supracerebellar approach, okay?
Okay.
And this supracerebellar approach, as you know, was first described by us in about 20 years ago for petroclival meningioma. You know, Swami had described first retrosigmoid approach, but this supracerebellar approach was first described by us, okay? So
Right.
I want you to enjoy the supracerebellar approach.
Of course. So, how did this patient presented, Abida
How did you
or
present
Atul?
them? No, no, ये dry couple.
Anyone knows the presentation?
Ravi, what is the presentation? Just tell. Only date में ये डालना अभी इसको.
Sir, can you tell us something about positioning?
Yeah, positioning. This is sitting position. That is also very, very important. Sitting position. The other thing is, you know, I have done little bit flexion of the head. I am using these special drapes which have been provided to us. No, sir. Okay, so now give towel.
These are from Surgiware or some other company?
We also have Surgiware, but this is from Varvi.
Okay, okay.
I am using it for the first time.
Oh,
Let us see how it does. So head sitting position, flexion, not so much like acoustic, little bit less flexion.
some noise coming from your phone.
आवाज कम करने को बोल.
यार थोड़ा साउंड वाले देखो.
Some other mic on over there.
Ravi, go ahead.
Yes. Yes. Yeah. Okay, any seventh, eighth
ये निकाल के.
Except
on examination, did you find anything? You're saying about the redness, so does he have any?
Is there any?
Corneal reflexes? Okay.
Sensation for me is there.
Corneal reflexes are okay, sensations? Decreased. Yeah.
You like? You like? Yes. और कौन सा? वेरी कर सकेंगे? Okay, now.
Sir,
Ah,
I remember that, you always look at T2 weighted images when you're doing meningioma surgery.
yes, yes, yes.
Can you tell us why, what is the significance?
T2, will give the consistency of the tumor. In this case, if T2 is white, it will tell you that it is soft tumor.
So I think here we don't have a
No, no,
hyper intensity.
no, we have.
So you're expecting this tumor to be a soft tumor.
Yeah, this is quite a straightforward tumor actually. I did not get a good, but there is no case straightforward and no case easy in neurosurgery. That we have to remember. No case is straightforward, no case is easy. Considering that the tumor is involving the fifth nerve, considering there is trigeminal sensory loss, I expect the tumor to be not so easy.
You can take microscope, Atul.
Very soon, Lucky. Just let me.
Okay.
Fifth person. Lucky,
Yeah.
here in Sumaya,
Oh.
I'm, having quite a big, beautiful plans to develop it into a
Fantastic.
into a center.
Yeah.
And I hope that I can get more people here. Dr. Dev Pujari has shown some interest. Dr.
Okay.
Dr. Suresh Nair has shown interest.
Yeah.
So let me see how I can.
Yeah. Of course.
Here we got first de novo microscope of city of Mumbai.
Really?
Yes.
We're buying one. We had an old Zeiss Fentero, changing it.
And here we have got all kinds of drill system, anti-stack drill system, and whatever else is required actually. If you have a good microscope, you need nothing else actually.
Absolutely. Yeah. And you don't use anything else
Yes.
like navigation or endoscope or. So you are a cheap neurosurgeon to employ. Technically from the hospital side, because anyone else will come will ask for all this.
Drill? Yes.
I'm not saying it's cheap on payouts, but from the hospital side.
Nowadays, I'm not a poor neurosurgeon, let me tell you. Those days
Are
are
you
gone.
never? You never were.
Now, today I count money by weight.
Excellent. So Ganesh, Saraswati, Lakshmi, all three gods have to be there,
Oh, yeah. I only see. बोला वो चलना बंद कर दिया.
कैमरा एक जगह खड़े रहो यार. Makes us busy. Thank you.
What is the problem in this group? No? I think that I think definitely. Okay, my question. Definitely.
So can we take the microscope now?
Yes, yes, yeah. Very soon, very soon. That will come. Let us take the microscope now. So we can look at it. कुर्सी लो इधर। माइक्रोस्कोप उधर जाओ। कुर्सी आने दो। ये focus करो। कुर्सी आने दो। आने दे कुर्सी। अंदर जाने दो। काय काय साउंड ऊपर का लाइट बंद करने को बोले। ऊपर का लाइट बंद करने को बोले।
To give a little nibble, yeah.
A small piece of veggies or yes. Okay, जब तक जल में
Would you do more bone work, Atul, or
little bit, you know, here the sinus is not.
and the angle?
That's
Yeah, that's right.
Nibbler. See here you can see the transverse sinus.
Coming up.
The image is clear, Lucky, here.
Let us see.
Much better, much better.
Okay, one. Here to first second now. Here to first second now. Now here, Lucky,
Yeah.
you know, normally for acoustic tumor,
Just center a little bit, please.
wait.
Yeah.
See for acoustic
See.
tumor,
That's better. Thank you.
for acoustic we take this incision. For supracerebellar, I am taking this extra incision here. Here, this is back. You can actually back. No. Back, please. No. This is too long. It's a derivative process. It's up in the hand. The first thing, I'll open the cisterna magna, okay?
Right.
You know, I know in the audience, there are many young neurosurgeons and residents are also there, I know it.
Yes.
Cisterna magna is so important. See, I opened the cisterna magna.
Yes.
See, there are lower cranial nerves there. I can see little bit tumor also hovering near the lower cranial nerve.
Hmm.
So once I have released the CSF, then I will go towards the supracellular approach. Okay, release. Tighten.
Little bit off center, Atul.
Yeah.
Thank you.
Retracting my hand. You have gone supracerebellar, and here is the tumor. You see, Lucky, how quickly you can expose the tumor?
Straight away. Yeah.
Straight away. You know, if you go transfixers, which many people in the world are still doing, you will take a lot of time to reach the tumor. Light, light. Just a release. So here is the tumor. Tighten.
Yeah.
Stop the anesthesia. Now what I'll do is I'll work. Stop the anesthesia. He said, I have got some sharp venous in my penis. See, now what we have to do is we have to learn the art of breaking the tumor. You see, attached to
Yeah.
the tentorium,
Mhm.
attached to the tentorium here,
Yeah.
then I'll break the tumor. Suction is not so good, huh? But see here, there will be one pituitary vein will be there.
Yes.
It's a little bit long. There is one small biopsy process which I have got in that box.
Is the consistency matching your expectation from the MR?
Yeah. Not so bad, not so bad.
Hmm.
Finish the shot. Because you get my benefit.
Professor Ramani is in the audience.
Oh, very good, very good. Welcome, sir, welcome. But
Doing a petrocranial tumor cell. Yeah, pictures.
see the tumor is attached here.
Yeah.
Stop them. Remove the receptor. Tighten.
Sir, Dr. Ramani will like to say hello to you.
Yes, yes. Sir, welcome to you, sir.
Thank you, thank you. I'm very delighted to be here
Thank you.
and I made so many friends of mine here that I get very happy here, very happy to be here.
Thank you so much.
And your surgery is going very well, excellent, absolutely. Everybody is enjoying here. So it is a tremendous effort, excellent, excellent, very,
Thank
very
you so much. Sir.
congratulations.
This is the third case, sir, since you arrived a little late.
Thank you. Down, down. Back. Back. Finish the day. Go back to the. See, I'm inside the confines of the tumor, okay? I'm not, I'm, because of the consistency, I know that this tumor is displacing the nerve. Release the receptor. Okay. Stop it. You see, you get my benefit. Okay, see, back to the. Yeah. Okay. Smaller back. Wait.
And you feel whether they originate from the tentorium or petrous?
Well, that lucky I didn't hear what you said. See, it is
Do you
attached.
feel at this moment of time whether the tumor is coming from the tentorium or
It is coming from the tentorium. Let me show you very soon.
that's what I thought, yeah. No, it's slide anteriorly, no? Yeah. Petrous.
Bipolar. You see, it is attached here. Bipolar. See, I'm going to coagulate
The tentorium.
the tentorium. You see, on. Right.
But is it also attached to the petrous dura?
Yes, yes. That I will show you now. You see here,
Okay. Hmm.
there will be fifth nerve just hovering around in that area.
You can call it petrotentorial.
Hovering. Hovering. Also here. Here. See, I'm progressively debulking the tumor.
Yeah.
See, I'm not coagulating it too much, if you realize.
Yeah. And the superior petrosal vein would be a little lateral, I guess.
Maybe, I'm expecting it very soon here. Once I get the petrosal vein, the trigeminal
Yeah.
nerve will be located just
Ex-
medial to it.
Exactly. Exactly.
Then that Okay, let me see another. Okay, Okay, no problem.
Suresh, he's coming
Oh,
to
yeah. No,
Jaipur.
no. Okay, release the reception. Right. Okay, do you what one coming? Stop there. It's a knife, sir. Give knife. Give. It's a microphone. Are you able to see, Lucky?
Yes, Atul.
Or
But you know the clarity
not
of
yet?
the image. Yeah. I don't know if someone can have a solution to this.
Not good, huh? Clarity.
Yeah, we can guess. I mean, but what you are seeing, we are not seeing.
Poor clarity.
Yeah. It's like working under those olden microscopes. You know?
Maybe. Problem.
The Kinova should have AI also.
Tangerine.
Okay.
We are not seeing.
Yeah.
It is from the 10, it will be put interior.
Yeah.
Since we have now, it is from the 10, it will be down. From the aspect.
Push down to the up.
After this is the main down. 10 will put it down.
Okay. Stop doing it.
No. Yeah. Oh, you could be right. Hmm. Hmm. Yeah. Edge is free. The tent looks pretty free, Atul.
You see, there is.
Yeah.
Check. Hello, check.
See, it was going above the tentorium. You see how I delivered it? You saw?
Yes.
Yes, yes, beautiful.
See, beyond that is the fort now. I'll show you just now. You see the fort now?
Oh, yeah.
Yes, sir.
Stuck to the tent. Uh,
Hello,
Yeah.
hello,
Yes, yes.
sir, good afternoon.
Oh, my goodness. All right.
So this is beautiful.
Oh, my
It's
goodness.
like a movie going on,
What is going on?
like a movie going on, sir.
Okay, okay. Then it's the top.
So you are using good magnification, sir. It is a
You see
10x?
You see the pecan here?
Yes, sir. It can very well be identified.
See, that is the most dangerous part of this operation, okay? To identify and save the pecan. This is the fourth now.
Yes. Yes, sir. It is very well visualized.
And here is the third now. You see here, just beyond. Wait,
Uh,
wait, not yet shown properly. Let me show you after some time. Okay, really?
Sir, this is a 10x magnification.
I don't know why you are confirming.
कौन बोल रहे भैया? Oh, yeah, of course.
Yes, sir. We can very well see the interface between the tumor and the cerebellum.
Just wait, my friend, just wait.
Floating. It is not full tent. Not yet.
The most important thing is the become active. Once I have that in my control, then I am quite safe. See, this
Okay.
is the site of
Yes.
attachment of the tumor. You saw? This is the
Oh,
Yes, sir.
this is the petrous bone. Now just here will be the fifth nerve.
okay.
Stopping.
Hmm? Hmm. Normal.
Okay, my dear friend, now you see.
Ah,
See the 7th, 8th nerve complex here. You see here?
Yes, sir.
okay.
Yes, 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 very clear.
This is the site of attachment of the tumor.
Ah,
This is the petrous zone where the tumor is attached.
okay.
Microstatic.
Now, slowly, slowly float up.
These people are wearing this coat, so I am also going to go in.
Do you feel cold?
Nobody is there.
Microbiology. I want microbiology. You can get microbiology. That's delicious. Right. See, there is the fish now. Can you see, Lucky?
Yeah, just
Wait,
coming
yeah.
into view.
Wait, I'll show
Little
you.
bit, again, little bit
Wait,
out of focus, like what?
see here.
Hmm.
Wait. See here.
Hmm. Yeah.
That's small. It is illegal. Okay. Wait. Wait. Right. Yes, people is following. Okay, now See the 7th, 8th nerve complex here.
Yes, coming up. Yes. It's quite free, no?
It looks very free. You know,
Yeah.
Lucky,
Yes. Interestingly, you don't have an acoustic this time.
yeah.
It's a bit strange, but
Right.
anyway.
You remember I did 5 acoustics on one theater?
So maybe Abhida could have got something from KM, but she cannot, I guess.
Unless people is free.
Yeah.
So
They could have made it free.
Yeah, right.
Yeah.
Now you see here, Lucky, let me show you the anatomy of this area.
Okay.
Yes.
Okay, next.
Hmm.
See this in petroclival meningiomas, this artery is the most vulnerable to damage, and that is here. This is the PCOM and PCA.
Yeah. Yeah.
You can see now.
Yes.
See here is the here is
Posterior
the
cerebral.
here is the 4th nerve here.
The 4th nerve. Okay.
Okay. This is the brainstem. If I go medial, I will get into the basilar artery.
Hmm.
Okay, that is one shot. Okay, now next thing is I want to show you the 5th nerve.
Yeah. Hmm.
Nobody should be seen so well. Neatly. Nobody is seeing it well.
Yes. The microscope.
This is the clavus. Okay.
Okay.
That's
See, this is the fifth nerve here. You see this fifth nerve?
Okay.
See, that is why she has corneal absent, and that is why her eyes are becoming red. Because this nerve, this is the nerve which is quite badly entangled into the tumor. You saw the fifth nerve?
Yes.
Is the vision okay, Lucky?
Yeah, we can see the nerve. It's a very big nerve.
Bennett. See, this is
Uh,
the whole thing.
Atul,
Yeah.
what is the nerve above the fifth?
Here is the third nerve here, this one.
Yeah, that's what I was, beautiful. Hmm. So are you going to show us 3, 4, 5, 6, 7, 8, 9, 10, 11, 12?
Maybe. You remember, Lucky, huh? Really good.
Yeah.
With that Titan. Now let me show you the 7th, 8th nerve complex, which, as you know, in these tumors is the most critically poised. You see the 7th, 8th complex here? Let me show you properly.
Hmm.
Now I'm seeing from the CP angle. Focus करना.
Yeah.
You see this?
That's meters and that's 7th, 8th.
You see the 7th, 8th complex here? And
Very nice.
and here is the lower,
Yes.
these are the lower cranial nerve.
Yeah, 9, 10, 11. So 6, 7, 7, 8, 9, 10, 11. Saw the 5,
Really.
4, 3, yeah. Hmm.
Only I cannot show you the optic nerve. Right.
And olfactory.
Maybe I can show you the optic. Huh? Let me.
No.
No. Very. Lucky, this young boy is saying very easy tumor.
Yeah.
Battle. Everything looks easy, my dear friend.
Yes,
It is
yes.
in your hand.
And also, did you realize my strategic coagulation? I didn't go on coagulating the whole.
No. No coagulation, no kusa.
No, Kisa. You see, I want to show you the 6th now.
Yeah.
Then you see, here it is. Wait.
We saw it earlier.
Yes, sir, very well visualized.
Here,
Yeah, sir,
you see,
beautifully seen.
irrigation. So you see the anatomy.
Hmm.
Wonderfully, sir.
Thank you.
Very
thank you.
nice.
तेरे को तो अरमान सब कुछ अच्छा ही लगता है भाई साहब.
Sir, है ही सब कुछ अच्छा.
Title. Okay.
Sir, one question.
हाँ.
Sir,
हाँ.
what is the secret of your fitness, sir?
उस क्वेश्चन का आंसर मैं नहीं कर सकता भाई साहब. वो मेरी बीवी से पूछ घर के. बैठो. हाँ. This is the region of petrosal vein. You see here?
Hmm. That's going towards the Meckel's cave, no?
Yes, here the tumor was attached basically.
Anteriorly.
Back of the
Hmm.
I'm just killing the cell of origin, not that. Release the return. Release, sister, release. Right. You see, no Surgery cell, no cell phone, no nothing. Battle. You saw the supracerebellar approach?
Yes, beautiful.
See what a beautiful approach this one is. You see, in 1 minute you can expose the tumor.
Yeah.
As I mentioned, most people in the world today, particularly in US, they will do transpitosal. You see, Bennett and Rick Patton. Let me see. I have another pictoclival tumor. If I can do it today, let me see. What is the deal? Beautiful person. Beautiful. You know what, Lucky? In this hospital,
Yeah.
you know, like in KM hospital,
Yes.
I can operate completely free of cost.
Very good.
So that is the advantage. You know, some things if it is in Leelavati hospital, for instance, and if there is a complex case, you are a little bit scared. But here, you know, that luxury is there. You know, like KM hospital.
Yeah.
Now I'm going to show you, Lucky, a beautiful surgery for glam. And absolutely for glam, for a low-grade glam.
Glamour, okay.
Low-grade glamour, and I want to show you a different world of glamour surgery now.
Okay.
I only hope that relay is good and relay is not troubling me. You know what? Recently, with the work of Abida in white fibers, Lucky,
Yeah.
this white fiber work and our beautiful papers on subject of glamour.
So Kurinder was here. Yeah.
I think glamour surgery. Now you will see. I should not talk too much before I show you. Okay.
Yeah.
I showed you something in spine surgery, which you are still, which many people in the audience are still confused as to what the hell I did. But what I want to show you is the patient. Patient आया भरा है. Just take a small patient का जरा एक छोटा सा क्लिप ले, उसका पेन कैसा है बैक में, और यहाँ पे आके रिले कर. लंबर स्पाइन वाले का. देख उसको लेके जा, आपको मालूम होगा.
I think so, towards probably left.
You know what, Lucky?
Yes.
The spine patient, I have not yet seen after operation. But I can tell you now, and you know, whoever is listening must listen, that if that patient does not recover in her pain in her legs now, I will resign from neurosurgery and do some Himalayan trip.
Not yet, not yet.
I can promise, you know, 100% that patient
Yeah,
is
We got the
completely,
pinning.
completely relieved of her back pain. Back means little bit surgery pain will be there, but not
Yeah.
the pre-op. Let us see, this boy is going to come very soon.
Eh? Yeah, he doesn't touch.
Come, come. Bone dust. Get off. You show the bone dust. हो गया उधर का तैयार खोल। दबा इसको दबा ये इस पे फोकस करो जरा ये किधर गया आतुर किधर गया इसका पेन देख पेन पेन
Yeah.
Coffee time.
Go for a little coffee break, maybe. Atul?
We'll have breaking for coffee.
Yeah, we can. But whoever goes, please come back quickly.
Coffee.
नीडल ये किधर गया वो यार नीडल बिल्कुल मेरा मास्क ऊपर नहीं ना आएगा नीडल ले इसको जरा इधर आना जरा इसको ऊपर कर ये पकड़ पहले इसको इसको नीचे से ढीला कर इसको इसको ढीला कर बीच का बस टाइट कर ये अपूर्व किधर गया एक टॉवल देना सीखा बस प्रमोद तू इधर ही रह भी इसको बुला वो ये अपूर्व किधर गया बुला उसको बेवकूफ को गाउन खोल गाउन हाँ खोल गाउन हाँ पकड़ ले गाउन को अभी अच्छे से पकड़ ले और खींच क्या कर रहा है तू बाहर इसको कर स्क्रब कर कैसा है लंबर स्पाइन वाला हाँ कंफ्यूज मतलब क्या बोल रही
पेन है अभी देखता हूँ check
चल इधर दे अभी इधर फोकस कर.
Yes, sir.
जो जो इधर जरूरत नहीं है ना, जैसे अभी वो विपुल की जरूरत नहीं है अपने डेस्क वाले, इसको बोल वहां जाके बैठे. जो जो नहीं जरूरत. चल मेरा माइक चालू है क्या?
Yes,
Hello,
sir. Yes.
can you hear me?
Yes, sir. Yes, yes.
हाँ बोल बोल. Now this is a low grade glioma. You see that?
No, sir. We are seeing the closure.
Now दिखा उसको दिखाने.
Yes, sir. Now it is visible.
You can see.
Yes.
Now this is a low grade glioma. Low grade
Yes.
gliomas are also called diffuse gliomas. They are also called infiltrative gliomas.
Yes, sir.
So low grade gliomas are diffuse, right? That is the concept. Let me tell you the history of this patient. Now this tumor is located in supplementary motor area. Now Abhida,
Yes.
first let me, what I'll do is I will ask Abhida to tell you about the location in terms of white fiber tracts. Abhida, tell about the location. Don't remove the gown complete. उसको नहीं.
So if you
Take the
can see,
mic, take the mic.
image is here, you can see my finger. So this is the central circle here. This is the
Yes.
So the tumor is exactly located in the posterior medial superior frontal gyrus, which is the supplementary motor area. So now what happens in this is there are a lot of white fibers that come into play. Just below the tumor will be the SLF, the medial SLF. Below that will be the cingulum, and right in the depth will be the corpus callosum. So if you see this sagittal image here,
Give me
so
spirit.
this is the low grade tumor. You
Spirit.
can see the corpus callosum, and you can see a faint fiber like thing
इधर
going
screen
there.
लगाओ, L
It is
screen.
actually some fibers of the cingulum.
इसको
Now the
L screen
problem
लगाने
with
को
these
बोल.
tumors is
And
after removal, there might be a chance of a supplementary motor area syndrome.
many people who are not
Especially sits on the left, he might have a speech deficit. So this is, let us see how this case goes. Sir will explain along the way.
okay. What is the history of this patient?
Last 3 months, she's had 2 episodes of seizures. Last seizure, she actually fell down and had a black eye.
एक L screen लगाने को बोल. L screen. See this, Abhida देख. This is the corona. Now can you see the incision? क्या mic वो किधर रखा है camera? यार L
No,
screen लगाने को बोलना उसको मेरे यार.
Can cameraman show the position of the head?
L screen नहीं. इधर लगाओ. नहीं हजम के नहीं बचना. थोड़े क्या इसको.
Can you?
Next case, let us do AD only there. एपिडर्मल बाद में करेंगे. AD करो पहले, फिर पिट्यूटरी, फिर एपिडर्मल. हाँ टाइट करो.
Can you show the MRI meanwhile?
Show the MRI again. Okay, suction. Gauze piece. ठीक है ना. कैमरा लगाया इधर. इधर से लगाओ, यहाँ से पीछे से. माप दे माप. ओके, ड्रिल लगा के रखा है आपको. नाइफ नाइफ नाइफ. माप ले माप. इसको देखने दे थोड़ा उधर से. अरे लगाना भाई. टूथब्रश से. Curved sister.
Camera person, can you give the picture? Yes, now we can see.
Yes, sister.
Sir, we wanted to know the position
the audience.
Position is supine. And
Yes, with
just look, you see, this is the coronal suture here. Now, can you see? I'm not sure yet.
yes, sir, we can appreciate
You
that.
see the
That is
coronal
very well
suture?
seen.
So,
Yes, sir,
I'm
yes, sir.
skirting around the coronal suture. Okay?
Okay, sir.
See, this is a supplementary motor area tumor. And
Yes, sir. So
and
this is a parasagittal craniotomy, sir.
yeah, this is a parasagittal craniotomy exactly around the midline.
On the left side.
On the left side. So here, this patient will almost certainly get a supplementary motor syndrome. Just let us see. I hope there are some steps to avoid that. I will show you how to avoid that supplementary motor syndrome. Okay? And these tumors, low-grade
Right.
tumors, are very frequently located in this area. I am going
Yes.
to show you, you have seen about awake craniotomy and about all those things you have seen, right?
Yes, sir.
And now I'm going to show you a different style of surgery for low-grade glioma. So your drill system.
So the anterior and the
What?
so the orientation to the anatomy we wanted to see.
See, this is
audience
the
want-
nose here, nose. This is the midline. So, okay, drill this, put it. Section. Bipolar.
So
Mister, give me one more curved artery person. Wait. Okay, drill. Put switch. हाँ इधर से होती हाँ उधर नोज है हाँ drill.
So the bone dust has been preserved. Many in the audience feel that it is important to keep it after the surgery.
Yes. That's what okay, cutter. Yeah. Okay, cutter. इसमें मेरा वाला सेक्शन लिया ना, मंगा ली जल्दी से, क्योंकि ना मेरे को आई एम नो कंफर्टेबल विद दैट। बाय पोलो। हाँ। Give me one more curve, Rati, for yes, straight. Okay, do you have to first? ठीक है।
Camera is not in focus there.
Just a minute, my friend. This is the change. Bye, Apollo. Okay, now what I'm doing is, Bennett,
Yes, sir.
I am going to use the ultrasound. Bennett,
Okay, sir.
gel phone. Normally, I don't even sometimes use the ultrasound also. I'm not
Yes.
sure here. Okay, give me a glasses.
That is a very good modality, sir. Ultrasound.
Yes,
Sometimes in
yes,
place
yes.
of the intra of MR, we can, in place of that, we can use that. So,
11.
can we have the sir ultrasound view?
अल्ट्रासाउंड पिक्चर
tumor
दिखाओ
is-
उधर। लगा क्या हुआ?
Screen wala.
हाँ और बड़ा हाँ ये ट्यूमर है। I'm not sure if you can see on the screen.
Oh, so no, we are not seeing the.
अरे उसको
the
दिखा
scan
ना
has been
कैमरा
cut.
भाई साहब।
कैमरा उसमें स्क्रीन में दिखाना है।
ये है ना पूरा ट्यूमर। ये बाजू स्क्रीन दिखाइए प्लीज।
Can have the ultrasound or the picture in picture, yes.
Yes, yes. We can
need
see
to
the
switch it on.
screen.
This is the fast.
हाँ
Uh, The screen is not visualized of the ultrasound.
There is no picture on it yet, unless we are not able to see it. Through a window.
चल ठीक है ओके। Okay, I'll
Just
take the
tilt the
microscope
ultrasound.
first, okay? चल लो।
Okay, okay.
ये इधर लो। करा microscope।
Just tilt the screen of the ultrasound. It will be well.
निकल पीछे कर दो आराम से कर दो पीछे ले लो। इसको नहीं कवर चेंज किया। ये और ये मैं दिखा देता हूँ.
Ultrasound came with this, you know, what is this? Came with, you know.
Atul,
हाँ,
this is the sono wand or this is the one which comes to the microscope?
no, this is not the microscope wala. Microscope wala na is different.
Different, okay,
Can see that we will see in the epidermoid. Okay, enough.
okay.
Now you can see on the screen
Yes, we can.
Now you see, चल ले लो बस निकालो. इसको माइक्रोस्कोप आगे लो, ये बकेट को पकड़ो. Now I hope the microscope works well because you know what? The king of Leica is here and I will. Where is Nilesh?
much
बेटा
better.
अगर अभी नहीं चला तेरी जान ले लूंगा.
ना अभी बढ़िया पिक्चर आ रहा था.
तो टेबल नीचे आना दे. हाँ टेबल डाउन. बस.
So did you mark the tumor on the ultrasound? Atul,
हाँ. You see, this is the
you
tumor.
locate it. Okay.
Lucky, this is the tumor. Okay. Now
Any change on the surface?
you can
on
see
the surface?
image is okay now.
Yeah, better.
Light बड़ा. ये पूरा ही tumor है. ये भी tumor है ना. Light बड़ा से मिले. This is also tumor. The whole thing is tumor है. कौन सा नाम है? ये. Still here ना. This is normal. This is normal. ये छोड़ दे. Okay, stop now. Lucky.
Yeah.
मेरा section ले आना.
Yes.
बना लेना please यार तो. I cannot
This
do this.
picture is better.
Just a minute, Lucky. मेरा section ला कर. Lucky, the focus is all right.
Yes.
So you see, this is the tumor I can see on the surface. Okay.
There is little pallor on the
Little
surface.
pallor. Now give me knife. Stop then. Now you see the technique. I am going to show you a different kind of technique now. Okay.
Okay.
See the vein of this side. Can you see, Lucky? I am designing a
Yeah.
plane of dissection. Okay.
Yes.
Just give me regular minute.
Yes, sir, we can appreciate the tumor
Just
part.
अभी ना तू just देखते रहे बस. अभी appreciate मत कर. पहले देखते रहे. Okay. You see, what I'm doing is I am identifying a plane of dissection. Okay. Wait, wait, wait. You see the tumor, how I'm dissecting?
Yeah.
It's a small cut. Bipolar. Normally, you know what? You're seeing Lucky?
Yes, very much.
Bennett.
You are treating it like a meningioma.
Just.
I mean, hmm. So removing en masse. It looks like a low grade or what?
Bennett.
Atul?
Just a minute, Lucky, just a minute.
Yeah.
Bennett. Yeah, I'm breathing into it. Huh? Did you see, Lucky?
Yes.
This is a unique style of removing low-grade glioma that I recently published.
Hmm.
Bennett. And if you have realized that I have not coagulated even once in this operation.
Yeah.
अभी हरमन गया क्या भाग गया क्या हरमन
सर यही हूँ सर यही
नहीं मुझे लगा तू भाग गया डर के
नहीं सर मैं कहूँगा
You saw that how I removed it en masse like a meningioma.
Yes sir.
So इसमें क्या है कि you know what, there are two things. The concept is that we have introduced a new concept that low-grade gliomas arise from the white fiber and they grow along the white fiber and they displace the white fiber. This is a very fantastic new concept. That is. If you have realized that I have not coagulated even once in this tumor, and I will show you the
Yes
tumor.
sir. And the tumor has been out in 5 minutes.
That is another bipolar. See, in the SMA syndrome, awake craniotomy will not work very nicely in SMA syndrome, because you know what, SMA syndrome will any case come.
Right. Sir.
See, what I've done is, if you realize that I've avoided the region of corpus callosum and
Very good.
avoided the region of cingulum, you know, where the fibers from one side
Do you do any tractographies on the MRI?
Yeah, of course, of course.
You have this tractography, this patient?
Yeah.
Now, whether it
Bipolar,
correlates
bipolar,
well,
bipolar. See, the thing is, you know what? Basically, this kind of tumor resection, it is the game of your, you know, control of your suction. You see how I used my suction in my right hand? You saw that?
yeah.
Yes, sir. It was looking like a dissector also.
Bennett. See, I have avoided the region of the cingulum. Bipolar. You know, I think quite a safe dissection, right? What do you think? Here is the motor area. Motor area is here. Okay. Again, P1, P2 irrigable irrigation. Bipolar. Irrigation. Yes, Abhinav. Yes. बात नहीं. ठीक है. ठीक है ना? क्या? हाँ करेंगे. Yes. आ रही है. Yes. Happy. बात नहीं. हाँ? बात नहीं. क्या? हम्म. Yes. बात नहीं. Yes. Big happy. Yes. बात नहीं. Yes. Irrigation. Yes. बात नहीं. क्या? Mhm. That's enough. Then small touches. क्या आवाज कम करने का बात है। देने का सर एक सर जिम्मी जलता सर बात है। देने बात नहीं देने बात है। से इसको जरा बाहर को छोड़ तो जरा ऊपर कर। बाहर चलो। ना कहीं अटक रहा है कुछ। अभी भी अटक रहा है। वेट। ये देखो सही। मोटर एरिया से दूर है ना, मोटर से तो दूर है ना। दूर क्या से? ये क्या चलो। ये देखो। हम इससे पानी है नॉर्मल। हरमान ये क्या बंद ही हो गया क्या? कर निकाल दो ठीक है। ठीक है निकाल दो।
हाँ जी सर, यस सर।
यार भाग गया क्या तू?
नहीं सर, नहीं।
Everyone is here.
We were doing the hemostasis, so we didn't feel like disturbing you, sir.
नहीं, मुझे लगा तू सही है। I'm just achieving some so normally study that even this is not required. We are little bit.
Yes.
मत्सल है कि नहीं?
Very nice, sir.
Everyone is there.
Everyone is sitting here, sir. Nobody's moved an
I
inch.
has come. I
Very much here and I'm enjoying the show.
Lucky.
Yes, Atul.
I has come. I.
Yes, he.
Hey,
is, sir.
Aip is here. Aip.
I'm here, sir.
Yeah.
I'm watching.
So you watch the different style of glamour surgery, huh? I.
Yes, sir.
That is nice.
Can happen. Yeah.
Very good. Bye, fellow. Bye, fellow.
What is it?
Yeah. They're all sharing.
Okay, bye, Palestine.
Atul,
Yeah,
what did you see in the ultrasound? You put it in, but didn't tell us what you're looking at, residual tumor or hematoma or what?
no, she just did ultrasound. There is no tumor
Ah.
in this area.
Okay.
No, I have removed it en masse. So there is no question of.
Saw. Yeah, we saw it, but you brought the ultrasound back again. I was just wondering what.
See, this is the thing. You have to identify the normal from abnormal. My concept is that tumor arises from a white fiber tract. It displaces the adjoining tract. Adjoining tracts are involved by pressure, not by destruction. You can develop a well-defined plane of dissection between normal and abnormal. The question is whether you can do it or not. See, in that, you see how I use my suction, you realize that I was constantly feeling the border and constantly feeling the consistency by virtue of consistency, by virtue of color, and by virtue of, you see, the vascularity. You see, the whole tumor I removed without a single coagulation. Although I'm suffering a little bit here now, but that is, you're removing after all an intraxial tumor.
Yeah.
Then मेरा section है मेरा section. Yeah. ये ना रहे, यहाँ कुछ नहीं, इधर है, इधर। देने को देने। हाँ? देने को देने। आप समझते? ये क्या कर रहा था पता नहीं। बाय बोलो। देने। आप देने।
We lost the picture.
बाय बोलो।
Someone,
नहीं करेगा, नहीं?
yeah.
देने।
Atul,
Yeah.
you just looked at the screen, the monitor, the blood pressure was little bit high, 148 systolic. Would that bother you?
What? Yeah,
The blood pressures, I'm sure they are looking after it. When? When?
नहीं समझ, नहीं, खाना। देने। ठीक है। ओके, समय सजेशन से। हाँ, चलो। देख पाते इधर लिया कुछ ले 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 होल में हिल के मुझे उधर हिंदी से पता देने
Do you use any fibrillar and interaxial tumor sometimes?
tell you the truth, lucky I
They're
don't know.
expensive.
Today I used
Yeah.
Somex Surgical after a very, very long time.
Coagulation and surgery looks like a normal brain tumor surgery.
Dura, Dura to come. Okay, still space. Okay. This is good. Okay, right. Okay. This is going on Zoom, no? That's showing on the microphone is very important. That one, do you have to person? No? No? So, we are ready. No. irrigate करेंगे एकदम फर्स्ट क्लास है देखा एकदम ब्यूटीफुल है हाँ ओके चल इसको निकाल मार इसको जल कम से बराबर हाँ 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 वन दस हाँ ये तो हाँ ओके वन पीस है क्या चल ठीक है चल चल यार अभी क्या सिचुएशन है रेडी है लगा लगा कर कर कर
Atul. Hello. Yeah. What's the next case, Atul?
अरे उसको प्रमोद हेलो
Atul.
हाँ कैन यू हियर मी
Yes.
yeah I am now on the other case let
Okay,
us see if
just,
I am want to do one C1 C2 one more
Okay.
so by the time I am done I want you to become everybody to become expert on C1 C2
Of course. We need to see you there. The camera needs to move.
Right. Right. Yeah, Anirabhar, yes.
One more case only.
Huh?
One more case.
You have only one more case, Atul?
What's that?
You have only one more case, or
We have 3 more cases. Let us see how many I can do. Lucky, I'm not sure.
no, that's fine. Just asking.
Nikal de upar.
We need to see you there though. The
Yes,
screen needs to change.
yes, yes,
There.
yes.
Great. Hopefully.
We are seeing your hand.
Just a minute, just a minute. इसको थोड़ा ऊपर ले लो, नीचे से. हाँ, टाइट करो. Okay, shift. Mark from me. मार. पैर पकड़ो. बस बस. सरक सरक.
This after that.
चल head high कर. Head high.
Right ball and down.
पैर ऊपर. एक सेकंड.
Maybe
कर कमर सीधा कर. Head high. Head high. हाँ, पैर ऊपर. चल इधर आजा प्रमोद, इसको ढीला करो. बस. हाँ, पकड़ के रख, गर्दन पकड़ के रख अपना. उल्टा. हाँ, जाने का नीचे. हाँ, नीचे. इसको भी ऊपर. Okay, tight.
need to see Atul, we need to see you.
Yeah, master.
See you positioning.
Sir, we are not getting the picture of external camera about the position.
बस टाइट करो.
Yes. That's better.
चल इसको ये लगाओ रिंग.
So you have the head floating.
Yeah, just now I will put the weight now, then it will float like this, you see?
Okay. Hmm?
नहीं ये टेढ़ा है नहीं. चल वेट लगाओ. छोड़ दे. Okay, छोड़ दे.
So how much weight you're putting normally, just for audience?
5 kilogram.
5 kgs.
10. थोड़ा हेड टर्न हो रहा है. हाँ ऐसा. Why it is turning like that? इधर. ठीक है. ओके.
It's not going over a boogly.
No.
And how they go over.
स्क्रब कर रवि जल्दी फटाफट. Immediately.
Sir. Hello. Sir, what is advantage of head floating position?
हेड फ्लोटिंग का एडवांटेज ये है See, one thing is there is no pressure on the eyes, no pressure on the cheeks. You see here? And also you are convinced that the weights are acting. Otherwise, you are not even convinced. And also it is taking you see the complete weight on the traction and it is floating. Most important is it is not even touching the eyes and cheek, nothing is touching. The scrub kar अच्छे से घस दे.
So tell us the clinical story, someone please. Abhida. Apurva,
Yeah. Clinical story.
please tell us the story and show us the pictures if you have.
Okay, गाँव खोलो.
So what is the standard body going down?
ठीक है. ये किसी को बेच के ना पाइन वाले का पता कर. अपूर किधर है? माइक्रो सीजर जरा अच्छे से करो.
Hello, sir. Can you hear me? Sir, am I audible? Sir, Ravi here.
Yes, Ravi, please.
Sir, this
I'm
is
sorry.
yeah. So this is
Yeah.
a 30-year-old female. She complains of very severe neck pain, and she has typical symptoms where on neck flexion she has numb sensation in all four limbs, tingling sensation in all four limbs, typically on flexion of the head. Apart from that, she has mild stiffness in the lower limbs, but not very significant in her complaints. Sir, on examination, she has severe hyperreflexia in all four limbs. Sir, on radiology, if you see, this patient has these are flexion films. If you compare with the extension, on flexion there is mild increase in the atlantodental interval with mild increase in the basilar invagination also. And there is also lateral subluxation on flexion, sir.
You have the coronal.
So these are the flexion extensions.
Yeah.
There's mild increase in the VI.
Hmm.
And on lateral inflection films, you see the inequality of the odontoid, that is lateral subluxation.
Yeah.
Sir, hello, sir.
Yes.
Abhida. Sir, now this is a case of vertical atlantoaxial instability. Okay, so there is an element of central atlantoaxial instability in this patient. If you see the facets, they are in alignment. But if you see the flexion and extension, I will show you. This is the flexion. See the odontoid tip here, it is going above here. And if you see the extension, it is coming back down. If you can see it here.
Yeah, we just saw Ravi showed
Yes,
us.
so this is the entity that is central atlantoaxial instability. In this, there is a subtle vertical atlantoaxial instability. If you see the facets, they are completely in alignment. Patient has spastic quadriparesis, neck pain, and classical symptoms of cervicomedullary compression.
Okay. So what about the groove of the vertebral artery here? Any problems? Avida?
Significant, sir. It's just
Can you see the coronal? Yeah. See the coronal one?
Coronal, actually, the cuts are here, a little bit cut, but if you see this image, here you can see a good chunk of bone that is there. Here also on the medial side, there is a good chunk of bone. So vertebral artery should not be an issue. Right side, we'll just see if it is little bit coming in the way, but doesn't look like too much. It should be okay.
The right groove looks little deeper,
Yeah,
no?
right groove is little deeper than the left, but see, if you see this image, here also you can see that there is adequate bone there.
Oh, yeah.
Yeah.
Yeah, it looks nice.
Yeah, it looks okay. Now you will see intraoperatively the instability.
Yeah. Abida, you have the MRI picture there?
So this
Tau
side.
clip, tau clip.
1 minute, I'll just put it.
Yeah, no problem. Just wanted to see the compression.
So now you see
Yeah.
that there is no compression here.
That's right. This is what I was wondering.
Yeah, but now patient has clinical signs of compression, and now you will see intraoperatively. Okay.
Yeah. So, does it mean the position of the neck during the MRI,
No, 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 no.
the atlantodental distance is little more here anyway
Yeah.
on the MR, but CT is more accurate.
Yes.
Thank you. But no cord edema.
Clip, tau clip. Tau clip.
So Atul, your team is equally brilliant here. They let you do the fifth case by 1 o'clock, eh?
Yeah. My team anesthesia.
Amazing. We must thank them, the anesthetic team on both sides.
Yes, Lucky. Thank you for reminding me. Normally, I just, sometimes forget to thank them.
Yeah, I know that.
What?
Sir, can you ask, is there any dynamic MRI done?
Okay, suction.
CT he showed me. Do you do any dynamic MRI? This is a question from the audience. Atul,
Yeah, what? Yes, Lucky.
do you do any dynamic MRI? Like
No,
you
no,
saw
no,
the
no.
dynamic.
No dynamic MRI, but dynamic CT scan is there. Flexion.
Yeah, we saw.
Yeah.
Yeah.
Dynamic
Thank
CT
you.
scan. MRI is not really necessary to do. With participant Caesar.
So next time you do in Somaya,
Yeah,
Then this, see, now we see the picture jumping. That is because of the net connectivity. With the cable, it will not be there.
Ravi?
nice, nice. Bye, Paulus. On? No?
Bipolar connected है?
हाँ ठीक है. Okay, chisel से बड़ा. Hammers. नहीं लाइट नहीं दिख रहा बराबर.
Right देना जरा. संदीप. हाँ, okay. Sally.
रवि अच्छे से रहता है. हाँ ऐसा कर ऐसा कर. रवि कर अच्छे से रहता. No, no, I cannot see only. अरे क्या हो रहा है? एक सेकंड 10 सेकंड. Remove this detector. Okay. No.
Sally.
ये थोड़ा little bit case, little bit controversial. रवि तो दिखा नहीं रहा है बराबर. हम्म. लाइट डालने को निकल the muscle निकाल के रख. Okay, now I am going for the station. Okay, for second station.
Okay.
Okay, nice, nice. For second, nice, nice, nice. ये आवाज ठीक करने को बोल दे रहा. दिमाग के Okay, microscope ले लो अभी. Now I'll take the microscope.
Yeah.
चल लाइट निकालो ऊपर को बस ठीक है. Next section. Section 3, section. Section D, section D. Bennett, Bennett. One more small reflector still. Okay, take per second knife. Power. Lucky, are you able to watch?
Yes, yes, very much.
Lucky.
Yes, Atul.
Now you see how
Okay,
much
well.
unstable it is. Can you see that?
Yes.
It is remarkably unstable, remarkably. Did you see that or no? This unstable. You see this?
Yeah, just move it again.
You see this?
Yes,
Still completely unstable. I can tell you, my dear friend. Still.
of course.
Okay, knife, sharp knife. Hill tera ready रख. Shot. Power.
We see the joint on the left side.
You can see the joint here.
Yeah,
You see here.
yes. Very clearly.
पकड़ ले,
Much
पकड़ ले,
better picture.
पकड़. थोड़ा टेबल ऊपर ले जरा. भर दे रवि. Sharp knife. एक सेकंड आकाश. Okay. Okay, go ahead, please. Go ahead. Bas. Lucky,
Yeah,
you can see how much the joint is mobile.
very open.
Unbelievable.
Yeah,
You see the whole thing is open like anything.
very, very open.
Small chisels too. पकड़ लो. दे रहे. भर दे भर. You know what, Lucky?
Yeah.
This patient is also neurologically quite much worse than the previous patient.
Yeah.
Tap, sister, tap.
Very interestingly, the MRI did not show much edema, in the cord.
I didn't hear that, Lucky. Don't be sister. Hold it. Don't be sister. Okay, plate and spin. Nonsense. Yes, do that. Minute. Wait a minute. Small chisel. Bennett to Bennett. Jalpa. भूल में कर देता ना बहुत चीजें भूल में का बात होता है बहुत चीजें भूल रही हूँ Taki, did you see that?
Yes,
I will tighten this lower one later, okay?
okay.
See now here again I want to show you the anatomy of this area, okay? Just see that properly. For
On the
second
other
knife.
side.
This is on the right side. Now you see this is the spinous process, this is the lamina. See it is already very fixed now after that left side. So I cut on the lamina here, okay?
Yeah.
Okay. That was the button. Okay, तो अंदर कर रहे हैं Howard. Now you see this is the lamina, okay?
Yeah.
Now my job is to find the pedicle. See here,
Just follow it up.
and what I do is I go along the pedicle, and here is the C2 ganglion, which
Okay.
I'm not manipulating the ganglion at all. You see, this is completely loaded by veins. You see this?
Hmm.
So I'm working underneath
Yeah.
in a subperiosteal plane. If you work in a subperiosteal plane, you can avoid the venous bleeding. You see, the
Yeah.
joint is completely open, like a completely unbelievable way. Knife to sharp. But there, see, now you see the whole thing. I can tell you one thing, my dear Lucky,
Yeah,
that this patient has got a new life already.
from one side. So she'll have two lives now. Atul,
Yeah,
when you write your autobiography, no,
yeah,
all these things should be there.
yeah,
When
yeah.
you become very old, you know, when you stop operating, when you are 85 or some 90,
Ravi,
yeah,
Lucky,
yes.
I never want to reach that level. Okay, give me more children.
You will live for 100 years.
See now, here is the joint. See, I have taken the. Wait, wait. See, this is the facet here. You see?
Mhm.
Wait, wait.
So right side, we were looking at the groove, vertebral artery was a little higher up.
You will see, my friend. Just wait. Minute. Hold it. Lucky Dr. Hande is there. Hande?
Dr. Hande, has he come? I don't see a hand going up.
That's
No. And some people probably didn't know that it is in Trident. I don't know.
no problem. No problem. Small bone pieces. Too.
Suresh Sankala asked me whether you are in Trident.
Yeah, yeah, yeah.
Yeah, he's on his way.
Okay, plate and position. Small position. Bench to bench. Okay, small season. Full makeup. Lucky,
Yes, Atul.
this live surgery is being relayed all over the world through Zoom TV, through
Is it on?
neurosurgical TV, and also
Aha.
that, also through Facebook and Twitter. So I will tell you how
Excellent.
many people are watching it at this time. I will tell you after some time. Okay.
Yeah. Don't add the China figures.
China is also watching.
So that will be in thousands then.
Let us see. Let us see.
You can put the after this. You are not easy.
I'm hungry.
Lucky,
Yes,
Lucky,
Atul. Yeah.
at least 1,200 people are watching, at least.
Wow. Facebook Live. Yeah, yeah. Hmm. YouTube and Facebook. Anyway, China doesn't have Facebook, no? China is a problem. Hmm.
Let us go. That's a nice. बंद हो गया था। हाँ, तो completely like a rock. You see this? Lucky,
Yes.
you see
Saw
like,
it very, very fixed.
like a rock.
Hmm. You did the final tightening.
Yeah, tightening is done, final.
Okay,
See this?
yeah. I was just wondering whether you need to do any more.
For a second, now. Okay, put the blue graph here. Lucky. Lucky,
Yes, Atul,
did you enjoy it or no?
fantastic. Hmm, switch. So what's the next case, Atul?
Next case is an acromegaly, giant not a very big. Patient is a giant, tumor is not a giant.
Yeah,
So it is rather straightforward pituitary tumor. And then there is one large CP angle epidermoid is there. And one more pictoclival is there. I'm not sure I can do pictoclival because there is some problem in getting permission for that patient.
I see.
And one craniopharyngioma is there. Craniopharyngioma, you think we can do?
Hmm.
Craniopharyngioma? No. Let's see it. Huh?
So by the time you get the pituitary ready, people can have lunch and come.
Okay, you
Quickly.
can have lunch. Yes, that's a good idea, Lucky.
Yeah, it's going to be 2 o'clock. So, thank you. You won't take any food, no? I know the answer.
Yeah, Lucky, yeah.
Have something.
Okay.
You and your team.
धीरज कहाँ गया धीरज हाँ, ठीक है वही मेरे को ही देखना है
Atul, what time you will come back?
In about 20 minutes we can you can have lunch for about 20-25 minutes.
Splendid.
Okay.
So we'll see you here at 2:20.
Yes.
Thank you. Thanks very much for a lovely demonstration of so many difficult cases,
ये
interesting
खोल जरा
cases.
इसको खोल अरे how was the previous patient? ये SMA वाला ठीक था ग्लामा चल आ जाओ देखें वो सब लंच के लिए गए हैं। हाँ मैं आ रहा हूँ, 2 मिनट में आ रहा हूँ, निकल दे।
तो लावलाच नाही तो विषय माईक लँड माईक घेऊन येतो बॅटरी बदलायला लागणार माहितीला प्रॉब्लेम
Check this, hello, check this, hello, check, check, hello, check, hello, check, hello, check, hello. Check, hello, check, hello, check, hello, check, hello, check, hello, 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 check, hello, hello, check, hello, hello, check, hello, check, hello, hello,
हा बोल हॅलो येते आवाज
hello, check,
नाही येत आवाज
hello,
हॅलो
check, hello, check,
हॅलो हॅलो येते
hello,
बंद कर कॅमेरा कॅमेरा
hello, check,
हॅलो 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 चेक माइक चेक हे
चालू आहे.
राहून देत कॅमेरा सोडून दे रे बाबा काढून टाक जाऊन देत हॅलो जाऊन दे सोडून दे कॅमेरा बंद कर देतो जाऊन देत नको सोड जाऊन देत आणि कोण बघत तर नाहीये हॅलो हॅलो हा पाहिलं माहिती दिसतंय मला दिसतंय कॅमेरा हो नको देऊ हल हा चल बंद कर तुझा हा नाही हा हॅलो हे हॅलो हॅलो हे 1 1 2 बरोबर आहे हा राहून दे सोडून दे बंद कर बाबा ते दोनच केस अरे 2 केस बाकी आहेत ना सोड ना आता जाऊन देत ना हॅलो हॅलो चेक हॅलो You can hear me, sir?
Can't hear you. Microphone a little bit louder, please. Atul's suction sound is coming. So tell us about the details of the hormones. How much is the growth hormone, IGF-1? Yeah. So we have the camera on the images. Yeah. Yeah, Atul, we can't see you. We can only hear you, your sound.
What's the growth hormone?
I'm asking you. If someone can tell us about the growth hormone levels. She already gone in sublevely. Okay. Male patient. Yes. So quite thick lips, big nose, and the approach. Done a submucosal dissection, paraseptal. Atul. Yeah. We did not see the CT scan. No problem. Yeah, of course. I'll tell you a story in the evening about relaxation. Not yet. Kal jayenge. Maya had come on the microphone and then OT में आया था. उनका जो main man. Distance बढ़ा दो.
Yes, sir.
Yes. Yes. Thick wall of the sphenoid. Yeah, see the sinus. Yeah, sure.
Okay, open. थोड़ा टेबल ऊपर जाने दो। चलो बस पकड़ के। वेरी गुड। होल्ड इट ना, होल्ड इट। टेबल थोड़ा ऊपर। बस बस बस। फॉरवर्ड कटा। फॉरवर्ड कटा स्टार्ट। ये लेंस थोड़ा क्लीन कर तो नीचे। क्या? Yeah, unfortunately, I cannot damn focus on that. Okay. Big biopsy कर सकते हैं। Backward कटा।
Luck.
This is a stella, okay? Small chisel. Eight second, 8 second, 8 second. ध्यान ही नहीं है ना ये प्रॉब्लम। Okay, chisels, the chisel. Gently, Marcy. Okay, forward का test. ये तो बहुत ही ज्यादा इसको निकाल, इसको थोड़ा बाजू में करें। Right. Yeah, as you can understand, I'm having some difficulty with this equipment. Okay, forward का test, backward का तो see, there is a tumor. You can see the tumor. Lucky, you're there or no, my dear friend?
Yes, yes, very much.
See, the tumor is coming out there. You see this? Clean this,
Yeah,
sister.
we saw in the MRI on the left side. Uh,
Forward का test. Unit and patty. Unit. Can you see the tumor, Lucky?
yes, yes, starting to.
No, no,
Yeah,
little bit
we
I'm
saw- we
having
saw.
problem. You are a bit, don't do this, all this.
So bleeding hai, so
Knife to knife. Micro. I just am completely uncomfortable with this equipment. See, the tumor is there.
it's all out in the sinus.
Yeah, right super सबसे छोटा. See, normally I'll not do this like this. But you know, I'm very, very uncomfortable with what I have here.
Mm.
ये तो give me smaller और ये बहुत ही अजीब किस्म का बैटरी वर्क. Give me 6 o'clock. Don't get worried, my dear friend. Give- See, this bayonet is also not going, sister, inside. Okay, give me that. Sorry. You see the tumor is out. Can you see that or no? Not very clear.
We saw the tumor coming out.
You see the
but,
you see the hole there.
Yeah,
You see the hole?
yes.
See the whole tumor is out. You see this?
Yes.
DNA and small surgery center. Okay, give me 3 o'clock.
It came out like a big nodule, huh?
You know, a little bit I'm having some issues. Don't worry. Then see the normal gland. Can you see the normal gland?
Yes. Little bit.
You see this? This is the normal gland. Can you see?
Okay.
Here?
Yeah.
I know I'm not showing you properly, but see whatever.
No, whatever you say is right.
Give me 3 o'clock, 9 o'clock.
Because you're
9 o'clock.
that clear.
No, Lucky, don't say like that.
No, I meant the vision, the picture quality is not that good today. But we
More than
we
quality.
saw the tumor coming out nicely.
See, this is the normal gland here. You see this?
Okay. Yeah.
Some tumor may be here. See, this is the normal gland here, huh? Okay?
Okay.
Not because I'm seeing.
No, it is. We believe you.
Gel pumps to gel pump. I'll just wait for some hemostasis. Then I'll go maybe further a little bit.
And then, meantime, they can show the picture and hormone.
Finish the gel from some, not gel from party.
Male or female?
Looks like a male fish.
They show the picture.
So the MRI, but I think we're not very clear. The sound was not.
Nical gaya na? Beautiful Nical. Yeah, I'm terribly uncomfortable with this microscope. Where is this Nilesh gone?
This is some other man.
What happened? This is a Leica or what? This is Leica.
Yes,
So why should it be bad? It was working earlier, good.
Bennett. You see now, Lucky?
Uh, Not really, but
Okay, now you see. Okay, Bennett. See, this is the normal gland here.
okay.
You see here?
Yes.
Where the hole is there, this was the tumor.
Okay, yeah.
6 o'clock, the chota wala.
It actually fits with the MRI description, but we were waiting for the full clinical details.
Bennett. Gel pump.
I know you're quite lateral on the left side.
You see, this is the hole where the tumor was.
Yeah, yes, yes,
Yes.
yes. We saw the gland and the diaphragm coming down. Is it bleeding from the left cavernous sinus?
Yes,
Or?
this left cavernous sinus, but now it will
Yeah,
stop
that's
because I have
well.
pumped the gel from there. And I
Okay.
think that's the end of the story here, although I could not show you properly, but I think it is very, I'm quite happy with what I have done.
Yeah, the tumor looks like to be removed completely.
Gel pump.
We saw it was hanging into the sphenoid sinus.
Gel pump.
Atul,
Ah,
when you are happy
Mhm.
with the hemostasis,
Hmm.
just go back to the MRI and show us how
okay. See,
and all the
bone tissue,
hormones,
bone tissue.
please.
See, I wanted to show you a beautiful pituitary, but I could not.
Well, as you rightly said, no tumor is easy.
But one thing I can tell you, this fellow is cured of his acromegaly.
Oh,
I don't do piecemeal like this. I little bit go around the tumor. But here, because of the various things. Tell me.
I must say, it looked like the whole of the nodule came out. There were a couple of like multinodular tumor.
Tell, ठीक है. We'll- Okay, खराब हो गया दूसरा. ये बहुत बड़े टाइप के हैं. Okay, just elevate the lip. Cut this, cut this. हो रहा है. Speculum. Get another one. Okay, stitch. अशोक, इस साइड का चालू वो देखिए पेशेंट लीजिए हाँ जा तो पोजीशन दे I don't think. Now I'm going to do one CP angle epidermoid tumor. Are you listening?
Yes, yes, Atul, yes. So you do the epidermid, is it?
I'm doing the epidermoid. The problem in this epidermoid is that there are cranial nerve deficits.
Okay.
He has seven nerve, he has, so such a thing normally does not happen.
The big one, or let us see the pictures.
It is not as big one as you had seen earlier.
Okay. Yeah. Also, before you go from this theater, there is a public demand that we must see the MRI and the lab reports
Of
of this patient.
Of this patient. Yeah. Apur?
Apurv is there.
Apur has disappeared.
He can tell us while you are getting the other patients sorted out. You can tell us later. There is no rush.
You tell Abhishek what is the thing?
Aram se.
He is having a echo is coming.
You know that there is a team of patients.
Professor Nair is insisting the professorial academic. Oh, sorry, you saying about the merosils.
Previously, we used to put 2 endotracheal.
People put so many things, catheters, and Foley's catheter also put, and ENT people love Foley's. We hate it. We use Foley's catheter. No.
No, for this.
I know, that's what I'm saying. Yeah, not for the. Foley's catheter laga ke.
Hold it.
No, but we.
मेरोसिल दूसरा है ना मेरोसिल कैचुलम निकाल ले नीलेश वेट 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 एक सेकंड, इसको निकाल बीच में से। ये ना, ये पेशेंट थोड़ा ऊपर लेना पड़ेगा। हाँ, नहीं, पेशेंट को उठा ऊपर। हाँ, इसको पकड़ के रख, ऐसा। हाँ, पेशेंट को ऊपर ले। ऐसा आएगा। पैर नीचे जाने दे, अभी ये थोड़ा बैक ऊपर जाए। अच्छा, ठीक है, लगा लगा। हाँ, टाइट कर। अरे यार, हाँ, टाइट कर, टाइट कर।
अतुल,
टाइट कर, अभी टाइट कर।
Atul,
ये हाथ निकाल कर।
अरे भाई कैमरा कहाँ दिखा रहे हो भैया?
टाइट कर, टाइट कर। लगा, थोड़ी देर। हाँ, कर अभी।
हेलो। हाँ,
कर दबा। हाँ, कर। दबा रखो, दबा। अभी ना थोड़ा पैर नीचे आने देते, सर पे बहुत प्रेशर आ रहा है। ओके, टाइट कर। नहीं, हाँ, बहुत प्रेशर आया, इसको दिखेगा बाद में। पूरा ऐसे ये पैर के नीचे पिल्लो डालने का क्या मतलब है? unnecessary है। हाँ, नहीं, उल्टा उल्टा। जाने दे, जाने दे। और जाने दे, बस। हाँ, ठीक है, एकदम बस ले अब। इसमें क्लियरली यू आर सीइंग द ट्रांसफर। क्या हो गया? नीडल है, नीडल है।
All of 2, 3 people, just jugular.
थोड़ा पैर ऊपर ले ले।
Atul. No, so he's not listening, okay. But then, so people are sleeping here, right? Then, the 4 attributes everybody should have. One is knowledge, other is attitude.
ये ले, पकड़ फोन ले, धीरज। I think last is this is last, yeah. कितने हो गए? ये 7 है। अरे वो मेरे इंस्ट्रूमेंट अलग से रखने को। रिंगे संजमा को ना आराम से करेंगे, क्योंकि वो साला ये ना, इसको, ये पेशेंट जो है ना, इसको अच्छे से तू इरिगेट करते रहना, क्योंकि ना इसका इन द पास्ट आई हैड वन पेशेंट हु हैड, ये ना, ये स्टेनोमास्टोइड के वहाँ खड्डा था, और वो खड्डे से साला इसमें भी एक खड्डा है। रवि, इसके बारे में बोल दे। प्रमोद, ये माइक्रोस्कोप इधर ले ले, ये सब बाजू में। हाँ, इधर उधर। माइक्रोस्कोप तिकड़े ले, तू इसको तू बाजू में कर थोड़ा, अभी तेरा। हाँ, माइक्रोस्कोप ले उधर।
Check.
आ गया
Hello. Sir, am I audible?
किधर है?
Ravi here, sir.
अच्छा इधर देख रहा है? चल ले इसको ले सिस्टम ले थोड़ा माइक्रोस्कोप और अंदर जाने दो वो बकेट हटा वहां से फिर ये जो है ना ये लीला का उत्सव है
Good afternoon, sir. Am I audible?
बस तो हो गया इधर क्लीन हो गया तू इसको निकाल वो अंदर जा
Sir, can you see the MRI
पीछे।
of the patient? CP angle epidermoid?
ओके चावल नहीं तू मत कर इसको ना यस इससे पूछ कहाँ के इसको ड्रिप चेंज करना है क्या नहीं सिस्टर ड्राई दे पहले
Diffusion restricted. We can see the epidermoid.
या जस्ट आई एम
What is showing us?
एक माइक
Sir,
इतना
Sir, this patient, sir, can you,
Yes.
sir, this patient is a 50-year-old male. Complains of headache. He also complains of asymmetry of his face. He has got mild left facial, left nasopharyngeal fold expression is not as well as on the right side. Even eyelid movement is also inadequate eye closure. Apart from that, he has got mild ataxia. No limb signs, sir.
Facial pain there.
No, sir, not typical facial pain, but he has headache, not typical facial pain.
Hmm. Hearing okay?
Hearing is okay, sir. Yes,
no hearing is also not okay
Oh,
sir,
now
hearing is also affected, sir.
this patient you know what epidermoid tumors normally will not present with cranial nerve deficits in this
Right.
patient there are cranial nerve deficits so this tumor is not a regular epidermoid.
it looks like going into the brain stem at one
Yes,
point.
it is going in the medulla completely.
Yeah.
Outlook. One more towel clip. इसको जरा ड्रेप को देखो okay bedsheet
This is your 7th case today, Atul.
yeah you remember I had done 9 in one workshop you remember
Yeah. Yes.
you remember I had done 5 acoustics in one day you remember
I do. We did four or five C1, C2s, remember? 5 C1, C2s in Calcutta in one workshop, in addition to others. Yeah, and before,
okay
शुरू में
when you sit, I will tell about something more.
Right. Share this, share it. Okay, nice. पकड़ के। कभी थिएटर में आवाज कम करा जरा। कुछ पर्से पे नाइफ। The texture is not good. Bipolar. Nice, nice. Bipolar. कुछ पर्से पे नाइफ। Okay, drill. अभी का Advance, sir. Will do. Cut on. इसको देख के फिर से small nebulous. निकाल दो. रख दे निबला. Bye, Paul. Bone back. Yeah. Okay, that's been nibla. That's been nibla. Moving command better than before. Okay, take the microscope now. Chair the chair. Microscope. Microscope. Microscope लेना. इसको थोड़ा ना कहाँ गया? इसको थोड़ा ऊपर का नीचे से खोल के. लकी माइक देखो, माइक चालू है क्या देखो, उसको बोलो मोहन.
Yes, चल रहा है, चल रहा है.
हाँ,
Cool.
ओके ओके लकी, ओके ओके भाई साहब.
We were waiting for you to take the microscope, so.
माइक चालू कर लाई. Yes, okay, double needless. Okay, 0 to perspective. Nice. Don't move the patient now. 0.
Oh, sir. Where is this? Sir?
ठीक ठीक है. Don't move the patient now. जरा भी पेशेंट को हाथ नहीं लगाओ अभी. Suction. Okay, Lucky, can you see? Lucky,
Yes.
my.
Yes.
Okay. Detecting now.
We are very much there. You can see the epidermal already. Yeah.
See, this is not a regular. It's not a regular epidermal. ये इको क्यों आ रहा है देखिए. Detect in my. No, just see echo is coming.
Yeah.
See, this is not a regular epidermoid, okay? Okay, tighten. No, 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 no. इसको ढीला कर. Okay, tight now, tight. Okay, release, release. Okay, tighten, tighten. Release. Release. Tighten. Suction. Clean it. Fire system. Clean it. See, we have to learn in neurosurgery the art of demolishing the tumor. क्या साला गुर-गुर दे रहा है? See, this is the. Yeah, yeah. Bend it. See, it is going in the canal. Can you see? That is why he has facial weakness and all. By system. Wait. Okay, release. Tighten. Yeah. 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 Right. Yeah. 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 Okay. Now let us go for the 7th, 8th minutes now. तो टेबल नीचे आएगा क्या? down. Janade. Janade. Bah. Now, Lucky, are you with me? Okay, now I am going for the 7th, 8th nerves, okay? Hmm. Then it. Then it. So Lucky, you are seeing the 5th nerve here. This is the 5th nerve, okay? Then step in it. And here are the 7th, 8th nerve fibers. Seriously? What? Let me see, my dear friend. I'm not sure. Then इसका माइक्रो सेक्शन लेके रखें। Completely demolish this now, huh? Clean it. Clean it. Clean it. Maybe 7, 8 times. थोड़ा टेबल नीचे आने दो। हाँ जाने दो जाने दो जाने दो बस चलो ठीक है। दूसरा दूसरा सेक्शन देना। ये दिल्ली के रिसेप्शन इसका रिसेप्शन में है टाइटल क्लीन छोटा रिसेप्शन ये see the lower cranials, can you see the Lucky?
We see that. 9, 10, 11. It's never ending, eh?
What's that?
The never ending tumor,
Hmm.
like Dharavi.
Resection.
Professor Suresh Nair was remembering your statement.
Yeah. Focus. It's quite a tumor actually.
Yeah.
Everybody wants to operate with.
Look at the man.
Flex.
What is Suresh saying, Lucky?
Suresh,
Actually, I am telling you, remove 33.5% only.
Was that?
he won't hear you because you remember you disconnected. So, yeah. He's saying that it's very difficult tumor to remove,
Yeah.
and if one is not careful, there will be multiple cranial nerve problems.
That's right.
And you are now taken out 37%, he says.
Yeah.
And every 5 minutes he's adding 1 or 2% only.
Reduce it.
Yeah, there.
CSF.
हाँ, ब्लॉक है ना सब. Flex and flex and flex. Interesting, huh? Completely avascular tumor.
Microscope नजदीक है ना?
It's like a hair growing, nail growing inside.
Infection में है.
Take out the tumor, meningioma and all that, brain fills back.
All those stents, subarachnoid space is not open, downstanding.
Other things larger the tumor is one through the tumor. Lot of space. The tumor will once you take out, brain won't collapse. You can still get more and more space.
In between vessel branches.
Yeah, I'm not going to dissect in this area now. See, also you see here, this nerve, you know, This is the whole of fifth now. So my feeling is lucky. I'm going to leave the capsule around the 7th, 8th now.
Yeah, that's wise.
Because you know this tumor is not a cancerous tumor.
No. Yeah.
Retracting my hand.
Hmm.
See the nerves and all, huh? Lucky.
Yeah, yeah. At least you decompress quite a bit.
See this
But
tumor is the very fact that this tumor has. वही है ना, this is the question. Yeah. See the tumor is this is the medulla here. This is the middle, middle cerebellar peduncle. I don't think, it is too much stuck. So I'm just backing off now, my dear.
okay.
Keyboard now. Keyboard lagao, keyboard. Now I will use this,
We will.
I will use
Yeah.
keyboard or the endoscope with the microscope. So this is a new tool. Let us see how we can see the anatomy here.
Hmm.
I'm not very familiar with this, but let us. Lalika, Mr. Lu. Hype is there, hype.
I there?
IP is there, right? Was here.
He was. Not
Right.
not there now.
Detected.
I was talking to Manjul.
Hmm.
So after IP is here. IP is there.
He just left.
Okay, okay.
Hmm.
Now you see, okay. Done. Now are you seeing the image?
What image? We are only seeing the microscope. I think they have to change the
Done.
screen.
Done.
You want to show us the image from your screen? No.
कैमरा उधर कर जरा. Can you see?
Screen change करो भैया.
Can you see Kinovo?
Not yet.
Kinovo नहीं आ रहा.
They have to change the camera.
Wait, just let me show.
It's like yeah.
No,
So after this, I to go there if he knows. He is not. I mobile phone is only.
Hmm.
Manjul.
दिख रहा है अभी?
Yes, yes. Yeah, go in there. So that's an endomicroscope, is it?
एक में हटा. See the nerve.
Hmm.
Turn कर. Yeah.
Yes,
Beautiful, huh? Yeah.
panoramic.
Beautiful. बस निकाल दो. Okay. So that's the end of the story, my dear friend. And now I think you can relax. And I will
Okay.
let us begin with our CME program. Right.
So,
What
this
is
is the last case.
what?
This is the last case.
There is one craniopharyngioma I wanted to do, but that microscope I'm not very comfortable, so I have decided not to do.
Yeah, then you also have to come here, na?
Yeah, yeah.
So we will wait for you to start
What is the time now?
4 o'clock.
I think you can start at 4:30 and don't wait for me.
Okay.
I will have to go home and come, okay?
Oh, okay.
So you start at 4:30, I will join you, okay?
Okay, as you like.
ठीक है ना अभी?
So with this, we, from all of us here in the Trident Auditorium, Golconda Auditorium, we really thank you. There's no words to express our feelings towards your persistence, patience, diligence, care for the patients, and the difficult cases that you have shown us, right from C1, C2, lumbar spine, brain tumors, gliomas, meningiomas, epidermoids, pituitaries, whatnot. So we are again grateful to you, Atul,
Thank you
and
so
all
much.
the team. Thank all your team, anesthetists, nurses. Big round of applause from all of us here,
Thank you, thank you.
and also to the Somaya group of hospitals and Mr. Somaya himself. So with this, we close the connection with you for today.
Okay, okay.
One more thing, Atul. Tomorrow, just for the audience, tomorrow the cadaver dissection will be in the Somaya itself.
And it will start at 9 o'clock.
9 o'clock, and it will be related to Trident, or people have to go
No,
there.
no, it will not be related to Trident.
So people have to go to Somaya.
Yes,
What is the venue? You will tell us in the evening, no?
yes, in the evening I'll tell you.
Okay. Thank you very much again.
Thank you, bye-bye.
See you soon.
Yes, yes.
Any questions from the audience? Anybody wants to speak? Anybody wants to say anything? No, it looks like everyone is convinced. Thank you so much.
Okay, thank you, thank you.
Bye-bye. Bye-bye.
चलिए कर देते हो मैं जाता हूँ चलिए मैं घर जाके आता हूँ इस पे ना पूरा बोनडस डाल दे यू रिमूव द माइक्रोस्कोप आई थिंक